Mic test. Mic test, check one.
I don't know if it's before. And it is. So if you. No, I don't. Kids left the house. Nothing but sugar. Like the one day, so no, my house was like vibrating. He's sitting in there and he's like this. So, yeah. Spanish festival. So. Oh, Lord. You hear that? Hi. Yeah. Well, it's that is the bottom. I'm like, well, it's better than yeah, it is. I stand. Here's like, oh, yeah. Absolutely. So, yeah. So like essentially you're before. Yeah. Last night.
The research mission of the Virginia Tech Crane School of Medicine is actually one of the things that attracted me to being part of both the Fralin Biomedical Research Institute and the School of Medicine. I love that there is dedicated time and effort put forth for our students to engage in substantial research projects, skills around critical thinking, around curiosity, around how to look into the literature, how to critically evaluate method. All of those skills will serve our students going forward.
Sarah is amazing because she balances being very academic and very inquisitive while also having just like a calming, fun presence to be around. I have never not looked forward to meeting her with research, even when I had bad news.
Having somebody who's always available, always open for feedback, gives you great suggestions herself, is able to help guide you in some of those questions that are unknown, or as a medical student we may not know how to navigate them. I always felt like I could go to her with any issue that kind of arose, and she was just always so willing to work through them.
She's really been a great mentor and leader in that sense of showing me how to collaborate with others, and then also how to be a woman in academic medicine or in academic research.
What I want the students to take away more than anything is the sense that research, no matter what you do, comes from a place of curiosity, and that curiosity can serve you really well in a lot of different realms of your life.
So much of research in our curriculum here at VTC, a lot of the success of it is based off how involved your mentor is and how much they're invested in helping progress your project. And I feel really thankful that I ended up with Dr. Parker as my mentor and affiliated with her lab for the past 4 years.
She cares a lot about me as a student and a person first, and so I've been really appreciative that she encourages independence but is always there kind of supporting us as well.
Pushing her students to really be the best researchers they can be and also kind of the best versions of themselves. I think that's what everybody wants in a mentor, so I just got very lucky that she happens to be mine.
To be even just a small part of this really intense period of time in their lives where they're learning so much, it's absolutely humbling. It makes me so pleased to think about them building on this foundation from the VTC School of Medicine and the difference that they are going to make in many, many lives going forward. It's actually the highlight of what I get to do on a day-to-day basis. I could not be more proud of these students.
Congratulations, Dr. Parker. You totally deserve this.
I'm super grateful to be in your lab.
I really appreciate all that you've provided me, both in professional and personal development over my time in medical school.
It has definitely made me a better medical student and a better researcher, and I think a better person overall.
You're so deserving of this Research Mentor of the Year award.
So thank you so much.
Good afternoon, everyone. Good afternoon. Good afternoon, everyone. I was looking for a louder one. Good afternoon, everyone. The excitement in the room is palpable. It's great to see all of your faces here today in person. This is the first time I haven't had to say at this podium, welcome to all the Zoomers, all right? Because the majority of people here are here in person. So good afternoon, everyone. I am truly delighted to welcome each and every one of you to the VTC School of Medicine Research Symposium for the class of 2023. I'd like to extend a special welcome to our visiting students from the future class of 2027 here to visit for acceptance weekend. Please raise your hand so we know who you are. The early birds who came early, nice to see you. All right, start imagining 4 years from now, folks, right? So it's just great to see everyone here now. And also, as we were going through the posters in the last hour, filling our auditorium today is just a wonderful sight. As I said, it's not often that our academic community can actually all gather together, but today we have an opportunity for all 4 years of our medical school class to be together, which is just fantastic. Since our doors opened in 2010, research has been one of the defining strengths of our medical school as we pursue our mission of creating future thought leaders in medicine. As one of the 4 value domains in the medical school, the research domain contributes in a major way to the success of our graduates as they pursue positions in residency programs that value not only the research that they've done, but also how it prepares our graduates to apply the rigors of scientific thought to clinical practice. Last Friday, we celebrated an incredible match day and had a chance to reflect on the impact the pandemic has made to this class of 2023. They were just launching their research studies as the pandemic arrived and changed everything. No doubt that these students' ability to move their research forward with incredible mentoring, despite the pandemic, contributed to their 100% match success in their first choice of specialties. So it's not just been an outstanding achievement, but with a lot of different factors that stood in the way. So congratulations to all for that. Along with our evolving curriculum in health system science, research is a key part of the VTC difference that distinguishes our graduates from students from other schools. By nurturing their curiosity and rigors of thought, we develop lifelong habits of practice. In their careers in residency and beyond, our graduates will have that key advantage wherever they go. They will have all the skills that they need to critically appraise new research findings and decide which ones should drive a change in practice. Congratulations are in order for each member of the class of 2023 for fulfilling the rigorous requirement of our research domain that in other settings would have added a year to their education. I'd also like to extend my heartfelt gratitude to the dream team of faculty mentors for all of your support and encouragement of our students. And I know that will be the focus of the next segment of our presentations this morning, but including and especially our honoree as our award winner for this year, Dr. Parker. It is now my great pleasure to introduce Dr. Michael Friedlander, a man who plays many important leadership roles at Virginia Tech and the Fralin Biomedical Research Institute at VTC. Mike is here today also as our Senior Dean for Research in the VTC School of Medicine. I greatly appreciate the outstanding leadership provided both by him and Dr. Leslie LeConte, our Associate Dean for Research, in assuring a truly exceptional research experience that culminates every year in this very special day. Dr. Friedlander.
Thank you, Dean Lehrman, for your kind words. And just want to start by saying congratulations to all of you. Every year, I'm more amazed when I see the work that the medical students have done. I had a chance to go to posters, look forward to the talks today. And for those of you that are visiting, I'm sure you will be equally impressed, as am I, at the quality of work that the medical students are able to do here in terms of original research. And Dr. Lehrman said it well about how important that is for a career going forward. So great day, really exciting to be part of it. As you heard a little bit, and I guess there are no secrets here because the name's been mentioned and the movie was running, so it won't be a real secret, but I have the great honor today of being able to recognize one of the outstanding faculty mentors. And really, we want to recognize all the faculty mentors. As you know, medical students have worked with them. These are your projects, of course, but those faculty mentors are so important in helping address the hurdles and guide and redirect when time is appropriate and give advice. So we're extremely appreciative that they take time to be part of this important endeavor. And just so people are aware of the process, a little bit about it, we ask for nominations for the most outstanding faculty mentor every year from the students, but also from alumni who have been here previously and had experiences with the mentors. And we get a bunch of those nominations. The criteria for selection for this award and recognition include creating an environment in which original hypothesis-driven research can be implemented and guided. Secondly, providing opportunities for professional growth for the student. Next, challenging the mentees to make original research contributions and carry the research to completion with rigor, and fostering intellectual growth, technical proficiency, and establishing clear expectations and maintaining high standards for quality research ethics and work ethic. So you all know those things don't always come easy, and it takes a team. We all appreciate nowadays about the teamwork of research and discovery and how important every member of that team is. This year, the person who's been selected to receive this recognition is someone who has actually a pretty long track record of mentoring in an outstanding way medical students. The awardee this year has mentored or co-mentored 14 medical students already. That includes mentoring a student who won the award or won a letter of distinction, I should say, for the research previously. And this year as well, student Allison Strauss, whose poster I had a chance to see a while ago, which was terrific. And so it really is a great honor today to be able to recognize the recipient of this award, which everybody knows is Dr. Sarah Parker. So please join me. Recognize Dr. Parker. One. And number two, something in this envelope. It feels like it's money or it's money to the name money. And I know this squares on it. And now Dr. Parker will share with us a little bit of her experiences and the privilege she's had of mentoring medical students in their research projects. Sarah.
So first and foremost, I want to say a huge thank you to all of you, especially the students who've been in my lab. Oh my goodness, I saw Becca, sorry. I'm so grateful to you all, and I'm really grateful to the team here, Dean Learman, Leslie, Dr. LeConte, and Dr. Friedlander. I could not have the opportunity to work with more talented folks. I am truly grateful that you give me this opportunity. In reflecting on this opportunity to speak with you all today, I kept coming back to what you all have been through as students over your medical school journey. So I started making a list. It is extraordinary the things that have changed about the world in the short 4 years that you have been here. We could not have imagined what this place was going to look like when you all arrived. I remember you all getting here, and this is a completely different space that we are playing in now. And you all are going to walk out there into incredible opportunities to help patients and to help them understand their world in a different way. I continue to think a lot about the dynamics that you all have been through. I remember our Zoom meetings. I remember trying to transition. How do we do research from a distance? How do we make sure that you are still getting your curriculum that you need? And all of that takes an incredible set of people trying to do the best by you all, by the students. So thank you for sticking with it. And you all are about to go off and do amazing, incredible things. I wanted to take a brief moment to talk a little bit about the research that we do in my lab and the incredible contributions that our medical students make in translating that research into action. So this is a quote from an old article from 2006, but I think it's really pertinent to the work that is occurring in the research domain here at VTC School of Medicine. We know that there's incredible basic science research that happens across all of Virginia Tech, specifically within the Fralin Biomedical Research Institute. But we have tons of opportunity to think hard about how are we going to implement these new treatments. And if nothing else has driven home that point, COVID made that incredibly, incredibly obvious, that no matter how amazing the scientific discovery is, implementation is a critical part that we have to consider along the trajectory of research. And alongside of that, understanding what's happening to our caregivers and understanding what's happening with the patients as they go through these transitions, as the world is shifting and changing. So in my particular area of interest, I'm really curious about how do we design healthcare specifically to be easier and safer for patients as well as for caregivers. So these are kind of the three driving quotes, I guess, that drive the work that we do in my lab. The first is from kind of the father of human error. You cannot change the human condition, but you can change the conditions in which humans work. And that is what we study. We study how people do their work and try to make it easier and safer to do. The second is from a mentor of mine, an emergency medicine physician, who often talked about, he would say, Sarah, if people generally come to do the right thing, and if they can't or don't, it's our job to figure out why. What is it about the design of the system that's making it difficult? And the third thing from Don Berwick, and potentially apocryphally allocated to him, but every system is designed to achieve exactly the results that it gets. And so when we think about our existing curriculum here in the VTC School of Medicine around health system science, I think a lot about these three quotes. How are we designing the system, and how are you all as future physicians and as folks who have just matched, how are you thinking about designing the healthcare system to be better for the patients and better for yourselves as clinicians? So this field that I am, my field and the field that we study in my lab is specifically human factors. So we think about how people think, how they do things, and then we try to apply that to the design of work. So again, coming back to that former quote, you're not going to change the human condition, but you can change the conditions in which humans work. So we're really curious about how do you design that. Married with that, we think a lot about how do we actually implement this stuff. You can have the greatest innovation or discovery, but if you can't figure out how to get it in use, it can sit dusty on a shelf. So that's why I'm very excited about implementation. Implementation, just for definition purposes, is how do we translate evidence-based practices, interventions, policies, et cetera, into day-to-day activities and day-to-day health. So our grounding question is, how do we design the work of healthcare to make it easy to do the right thing? That's both implementation and human factors all at once. So we start with that as our foundation, and then we build up within a couple of areas of thrust within the lab. We think about implementation of technology, different kinds of training that might help people be able to do the right thing, and then ultimately behavior change. So within these kind of three areas, we have a number of questions. I've listed the projects that our medical students are working on specifically so that I can highlight their contributions. So you can kind of see there's overlaps within these three different thrusts. So while keeping our research kind of questions at the core, we have a number of folks within the lab that are doing all of this different kind of work. Research is absolutely the penultimate team sport. You can't do anything by yourself. So I appreciate very deeply standing up here representing the work of many, many, many people. And this isn't even a complete list. I just am not that talented at PowerPoint. So this is what you got. So if you were in my lab, you're probably thinking to yourself, Sarah, you're on slide 8 of 12 and you've not even gotten to your methods yet. Hustle up. So I wanted to just highlight a couple of our projects and some of the things that we're doing. So we have a couple of folks working on implementation of a sepsis clinical decision support tool. That work you can see is just starting to kind of get off the ground. This little dip here. Ooh, let's see. This little dip here was the implementation of a clinical decision support actually in situ at Carilion Clinic. And so we're exploring pre and post that moment kind of opportunistically. How are people using this decision support tool? Are they engaging with it? It's a best practice alert. So do they just shut it down and blow past it? If so, what do we need to do to redesign that system? These pictures here you will recognize from one of the posters. just now during the poster presentation. This is some work looking at doing some additional training, testing and trying different types of training and different types of pre-training for folks engaging in Stop the Bleed, which is a national level program for lay people to better understand how to apply or when to apply tourniquets. And then this next picture here, again, you'll see this in a moment when Allie does her presentation. This is some work we've been doing in simulation, looking at implementation of training for opioid overdose. So we're trying to learn more about how exactly naloxone can be available and administered in the safest and most effective way possible. And then our most recent projects in collaboration with infectious disease, as well as the Virginia Department of Health, we've been looking at individuals with substance use disorders and issues with linkage to care for folks who are newly diagnosed with hepatitis C. So all of these may sound like completely different projects, but that underlying foundation of how do we design this work to be able to be implemented so that folks are getting the care that they need when they need it is the underlying goal. As both Dean Learman and Dr. Friedlander mentioned, one of the flagship parts of your education at Virginia Tech Carilion School of Medicine is your research. And I thought a lot about, what does a researcher's mindset provide you as you leave here? What are the takeaways? And it's not just a publication or a good poster or something that's really an interesting finding that maybe, you found in cardiology, but now you're going to switch over to ENT in your residency. These are things that are kind of generalized skills that you can take away. Obviously, curiosity, dissatisfaction with the status quo. That's what we think a lot about in health system science. Tenacity, professionalism. As you have gone through your research domain project, I am positive that your professionalism has been touched upon multiple times, communicating across diverse backgrounds and integrating multiple perspectives. Teamwork, optimism, often gratitude, because again, you can't do this alone. You have to rely on others. And then resilience. You all are exhibiting incredible resilience, probably at a different level than one would expect for people just transitioning to residency. So I want to acknowledge that incredible skill that can be applied to research, but is also something that you all have had to live through. So I hope you can take that skill with you. My hope for you as you transition to our M4 students, my hope for you is that you remain curious and dissatisfied with the status quo, that you are tenacious in your advocacy for your patients, for yourself, for your discipline, and for making a better system. I hope that you continue to think critically. Dean Learman just said, rigors of thought can be habits of practice. I think that's really important, thinking critically rather than just coming and getting the job done, thinking critically about what is happening and what you are doing. Caring for whole people, not just the patient that has X disease, caring for them as a whole person. Listening to your colleagues. Again, going back to the beginning, if they do or think something different, there's a reason why, and what can you learn? Considering that system, and ultimately to be just advocates, to have justice and that just advocacy drive your work for your patient, for those who cannot advocate for themselves, for a better system, and ultimately for yourself. So I wanted to say thank you. These are my little people. And I wanted to also just mention, there's a reality and then there's a reality, right? So as you go, one of the great things about research is that it's critically important to not do it. You have to learn from with things not going the way that you anticipated or you didn't expect. That is a really important moment, and important learning, and worth documenting and worth taking with you. So don't expect perfection, just expect the next best step. I'm really grateful for this award. Thank you. And thank you for your time today.
Thank you so much, Dr. Parker. Great talk. Always good to hear from you. So now we are getting ready to hear from our students. The next people that you're going to hear from are students who've been recognized with letters of distinction in research scholarship. And so we select those students for for this recognition based on what they write up and what they orally present about a year ago, actually. So students came in, talked to a committee of faculty, and we all met and evaluated which students best represented overall quality, significance, relevance, innovation, and then clarity to talk about their findings. So those are the criteria that went into choosing the students that you're going to hear from. Before I turn it over to our first presenter, I want to let you know that there are a few people online still, so we thank you for joining us. We are going to have questions at the end of each talk, and so we will be monitoring comments on YouTube, but also in the room here, you see a couple of microphones, so come on up and ask your questions. We have about 5 minutes at the end of these first couple talks, and our Director of Clinical Research Education, Dr. Nikki Worthington, will be monitoring those questions. So now our first presenter will be Maya Langman. She worked with Dr. Eli Vlisavljevic in the Department of Biomedical Engineering and Mechanics, and she also worked with colleagues at the vet school sort of across the street. And her work is she worked to study the potential of a technique called histotripsy for the treatment of brain tumors. Maya, why don't you come on up?
No, I'll just stand here. That'll be fine. All right. Hi, everybody, and welcome. My name is Maya Langman. I work in the Vlisavljevic Therapeutic Ultrasound Lab at Virginia Tech, and I will be presenting on the ultrasound-guided histotripsy for brain tumor ablation through a biocompatible sonoloucent cranial implant. So firstly, we just need to talk a little bit about our modality here. So our modality is histotripsy. It is a non-invasive, non-thermal, non-ionizing focused ultrasound ablative modality that uses an externally based transducer array to generate microsecond-long bursts of high amplitude ultrasonic energy to create a cavitation bubble cloud at an internal focus within the body. These expansion and collapse of these rapidly forming bubble clouds creates the mechanical destruction of tissues into subcellular homogenate, which are in these precisely defined lesional zones. Histotripsy has been typically used with ultrasound guidance, allowing us for real-time image monitoring during treatments as well. On the right side of the screen here, we can also see that histotripsy has already been approved for the ablation of hepatocellular carcinoma with this delivery cart there with that externally based transducer that then goes to an internal tumor ablation. It has also been proven effective for ablation of other tumors and other body parts, including the kidney, pancreas, breast, and as we'll hear from my colleague Tony later on, also uterine leiomyomas. So histotripsy intracranially has proven fairly difficult due to the presence of the skull within the acoustic field. You see propagation through the skull causes severe pressure attenuation of these therapeutic ultrasound waves, limiting our ability to treat through the skull and preventing us from using that ultrasound image guidance during treatment, which, as I mentioned before, is a key feature of our non-invasive modality. This here is a depiction of a bubble cloud, which is what we use for our ablation. However, histotripsy has shown promise for intracranial application with successful ablation of ex vivo gliomas, as well as a successful ablation of porcine brain tissue through an open cranial window. As such, in order to develop this promising modality, in order to address brain tumors clinically, we have really two options here. Either we use large complex array transducers with complicated aberration correction algorithms and resource intensive intraoperative MRI for guidance, or we figure out a way to get through the skull and eliminate that limitation. So that brings us to our study here, which will be the first of its kind. We investigate histotripsy for brain tumor ablation through a sonoloucent implant in a clinical trial using canine patients. So ideally, we would like this sonoloucent implant to provide a window through which we can ablate our brain tumors and will allow us ultrasound guidance during treatments. We would also leave it in place for long-term disease monitoring just with bedside ultrasound in the office.
So quickly, just a little bit about the implant. The implant is a biocompatible sonolucent cranial prosthesis that was developed by Dr. Francesco Prada and his team at Intelligenza Trasparente. It was specifically designed for use with therapeutic ultrasound to facilitate ultrasound beam transmission into the intracranial space with minimal distortion. All the way over here is a picture of our implant and a handheld imaging probe. And here we have comparative images across the prosthesis and without the prosthesis. And you can really see that there is minimal differences with imaging between the two conditions. In fact, it's already being used as such. So it has already been clinically implanted into a patient with multi-recurrent oligodendroglioma and monitored over a 30-month period with no safety concerns as of yet. And it has also been used preclinically for blood-brain barrier opening successfully in combination with low-intensity focused ultrasound. However, at this time, we have yet to investigate the sonolucent implant with ablative technologies such as histotripsy. So ideally, we would like to use that implant, as I said, as a cranioplasty through which we can ablate these tumors and then leave it in place for post-treatment monitoring with ultrasound. But first, in order to do so, we need to fully characterize the acoustic properties of our material through in vitro feasibility testing. And then these findings will inform our protocol moving forward into the in vivo canine clinical trial, of which I will be presenting preliminary data of our first 2 patients. So in order to recapitulate and expand upon a foundational study of the implant done by Prada et al., we started with single element tests to further characterize frequency and angular dependent effects of the implant. So we took single elements of fundamental frequencies of 500 kilohertz, 1 megahertz, and 3 megahertz, and submerged them into a degas water tank. A hydrophone was oriented at the transducer focus orthogonal to the face of the element, with the implant suspended in between, sort of demonstrated here. The implant was also suspended at predetermined angles of 45, 60, and 90 degrees between the hydrophone and the transducer itself, and output pressures were measured from the hydrophone and compared to an open water control for each condition. Our results first corroborated the findings of Prada et al. And confirmed that there is a frequency-dependent effect, such that increasing transducer frequencies results in increasing pressure attenuation across the implant. Our study then expands upon these findings and shows that there is an additional angular effect, such that decreasing angles results in significantly higher pressure attenuation as the wave passes through the implant. So first, the graph on the left here, these are superimposed pressure waveforms for each of our angular conditions. And I'll draw your attention to the green line, a little hard to see here, but we can clearly notice that there is a significant attenuation in that waveform compared to all other conditions. Additionally, we noted a prefocal shift along the x-axis for this waveform compared to the others. On the right side here is bar graph depiction of our pressure transference in the colored graph, as well as their associated pressure attenuation in the gray. All of these are normalized to the black free water control. And as you'll note, similarly to as I had mentioned, pressure transference decreases and pressure attenuation correlatedly increases as the angle becomes more acute with respect to the implant. We then move on to investigate the implant properties further with our multi-element clinical array transducers. Depicted all the way over here is our 8-element 1 megahertz transducer, which was designed specifically for intracranial application. This is based off of a porcine intracerebral hemorrhage model. There is a central opening in the middle that allows for our coaxially aligned ultrasound imaging probe that will allow for our real-time image guidance in vivo. We've tested this very similarly to the single elements in a degas water tank opposite a fiber optic hydrophone. Just briefly, our average pressure attenuation across the implant at that time was 49.5% through the implant, which is significantly higher than that measured by the Prada et al. Findings. But it does actually fall within the range of the angular effects that we noted for our single element testing. We can also see again that there is a prefocal shift in our waveform here, indicating that there must be some sort of phase delay that these elements are experiencing as they pass through the implant, and suggesting that maybe we have space to regain some of that pressure loss by accounting for this. We next moved on to optical imaging and found that even at maximum driving voltages of 250 volts, we were unable to cavitate through the implant at that time under those conditions. However, we did see more pressure transmission through the implant with our 16 element depicted here. So we did move forward with optimizing that 16 element transducer in vitro and continued with further optical imaging studies. Again, we have a very similar setup as before with our 16 element transducer submerged in a degas water tank this time. And then we have an agarose gel here for imaging capture, as well as our implant in between the two and a photron camera there. We captured images with and without the implant, in water and in gel, with and without aberration correction across voltages of 150 to 250 volts across 7 different pulse repetition frequencies from 1 to 1,000 hertz. On the right here is a theoretical depiction of our aberration correction. Essentially, as the waves pass through the element, they're experiencing some sort of phase delay, causing them to arrive at the focus at different time points. We just corrected these arrival times in our MATLAB driving code and synchronized the beams. In doing so, we were able to recover up to 18% of that pressure loss across the implant for the 16 element. So like I mentioned, it was a lot of data, but really what it boils down to for the purposes of our talk is these 3 images here. On the left here, we have our open free water condition with our 16 element transducer at 500 hertz and 250 volts. Then we have the addition of the implant here in the middle, and you can see that there is significant attenuation of our bubble cloud, as well as a shift of the focus prefocally, as well as some peripheral cavitation and destabilization of that central bubble. Then we do an aberration correction all the way here on the right, and we see that we can regain a lot of that pressure loss, shifted the bubble cloud back to its geometric focus, and lost some of that some peripheral cavitation, allowing us to have more focus on our bubble cloud, which is necessary for our in vivo treatments. So we concluded through all of this that we are able to cavitate through our implant at this time, but the clouds are still a little too sparse and a little too underpowered to be used clinically as of yet. So we are close, but not quite ready to treat through the implant. So we did move ahead with our in vivo study through an open cranial window and place the implant afterwards for disease recurrence monitoring. So that brings us to our workflow for our canine patients. Canine patients were recruited for the Virginia Maryland College of Veterinary Medicine. They received pre-planning MRI. And then on the day of intervention, they were craniectomized, received histotripsy treatment in the OR, went directly to MRI suite for another MRI, and came back for standard of care resection. The specimen were then sent for histopathological analysis, and our canine patients entered interval monitoring and recovery. At this time, we have treated 2 canine patients with spontaneous brain tumors, both with imaging characteristics consistent with meningioma. A lateral rostrotentorial approach was preferred in both cases. And after craniectomy, tissue-specific cavitation thresholds were determined visually. Here, you can see a small cavitation bubble cloud forming there, as well as through passive cavitation detection on our oscilloscope here. So 4 millimeter and 8 millimeter spherical volumes were accomplished in both, treated above threshold for the duration of the treatment, with single cycle histotripsy pulses applied at a pulse repetition frequency of 100 hertz and a treatment dose of 400 pulses per point. So the video here is, hopefully it plays. Yes, okay. The video here is a screen capture from the Histosonics delivery cart showing our real-time image guidance of our automated treatment. In the middle here, we see representative ultrasound images from a handheld probe before and after treatment, showing the formation of a hypoechoic region within the zone of histotripsy application. The last 2 pictures are our gross resection of the meningioma specimen with evidence of a histotripsy lesion formed on the cross section that we could visually see there. Here we nicely see the pre and post-treatment MRI side by side. You'll notice here on the top, our pre-treatment MRI, we see a well-circumscribed right-sided frontotemporal extraaxial mass with heterogeneous T2 hyperintensity. This is consistent with a large meningioma. We also clearly see that there is significant mass effect from this tumor with complete effacement of the lateral ventricle on that side, as well as pretty significant vasogenic edema in the surrounding parenchyma. The post-treatment images demonstrate successful lesional formation correlating to the zone of histotripsy application only 20 minutes after the treatment itself. It's a little hard to see from this distance, so I've circled it in red here, but there are radiographic changes 20 minutes after. The final histologic diagnosis for both patients was a grade 1 meningioma. Both specimens demonstrated multifocal infiltration by a mixed population of inflammatory cells and rare mitotic figures. Both samples exhibited precisely defined histotripsy lesions with sharp border margins of intact parenchymal cells outside of the targeted ablation zone. So you can see this very nice thin margin on the cellular level. Both canines tolerated the procedure well with no adverse events due to histotripsy before or after treatment. In patient A, we did note a mild blanching of the meningeal vessels, but there was no hemorrhage nor damage to the cortical surface noted. Both were discharged on post-op day 2 and did well. So at this time, we have concluded our in vitro testing of our single element and multi-element, as well as the optical images. We conclude that the implant does introduce both angular and frequency dependent effects, as well as a phase delay effect that we were able to correct for an aberration correction. While we were able to achieve cavitation through the implant with the 16 element, it's not quite there or ready to be used directly through for tumor ablation. So we did go ahead and treat with an open cranial window and did so successfully. Recruitment for our clinical trial is still ongoing. And I just wanted to thank everyone, including our funding partners at the Focus Ultrasound Foundation and the AKC Kennel Club, our partners at the Virginia Maryland College of Veterinary Medicine, specifically Dr. Ross Meisel, who is the surgeon on the project, and everyone at the Therapeutic Ultrasound and Non-Invasive Therapies Lab down at Virginia Tech. You guys are awesome. And specifically Lauren Ruger, my partner, and Eli Vysoplovich, who is my mentor. You guys have been fantastic for the past 4 years. So thank you.
All right, we'll take questions now in person at the 2 microphones, and we're also watching the live stream chat for questions.
Can you turn it on?
Thank you for your talk. Have you, with regards to the implant, have you looked at any thermal effects, I guess directly beneath the implant after histotripsy?
So can you hear me? Okay, sorry. So as I had mentioned earlier, one of the key beautiful things about histotripsy is that we do not have any, it's a non-thermal ablative technology. So we have not specifically looked at any thermal changes with respect to histotripsy with the implant as of yet. But I believe we are moving forward at looking at traditional high intensity focus ultrasound, which is a thermal based technology. And at that time, we would look at that. Thank you.
Wonderful talk, Maya. I just was wondering if you could speak to the use of canines in your in vivo model.
Yeah, absolutely. Great question. So the use of canines in the investigation of brain tumors itself is actually a really fantastic model for this entity. That being that canines regularly spontaneously develop the same types of brain tumors that we do as humans, with a similar biology, up to 80% similarity between the two. Additionally, these are clinical patients that they are well loved by their families and deserve very good care. So Not only are we advancing the veterinary field, but also creating an environment that we could translate to humans quite well.
Well, thank you.
Thank you.
Hey, that's fantastic. Can you hear me? This working? It's fantastic. You really made some significant advances for this whole platform from the work you've done, and really want to congratulate you. It's great, and it's hard work. My question is, with using the meningiomas and those being necessarily at the interface of ventricular fluid, it does throw a more complex geometry into the equation in terms of how the ultrasound interacts. So I'm just kind of curious, was there not an opportunity to go after a solid glioblastomas during this study? It seems to me you might have got some cleaner results, but what do you think about that?
Yeah, that is a great question, and something that I have definitely looked at and considered before. Our clinical trial is open for all tumor types in dogs as of right now. It seems to be the ones that we are recruiting and the patient population that their families are more willing to pay for these expensive therapies and move forward with seem to be the ones of meningiomas. So we have just yet to recruit any others.
Well, thank you very much, Maya. That was a fantastic talk.
So who's surprised that Maya's going into neurosurgery? So our next talk is going to take us to a slightly different scale. Our next presenter is Ellen Schranz. She worked with Dr. Jamie Smith from Fralin Biomedical Research Institute. Her project is titled Investigating the Role of Connexin 43 mRNA Localization on Protein Translation Regulation During Hypoxia. Ellen, you want to come up?
Right. Hello, everybody. My name is Ellen. I would like to thank everybody for being here today and for the research group for selecting my project. Today, I'm going to be talking about investigating the role of Connexin 43 mRNA localization on protein translation regulation during hypoxia. This research was completed in the Smith lab at FBRI. Gap junctions have broad implications both for normal physiology and pathology. They allow for two neighboring cells to directly communicate. They are comprised of 6 individual connexins that come together to form a connexon. 2 connexons from neighboring cells align to create this gap junction channel. And that gap junction channel allows for factors less than 1 kilodalton in size to pass between 2 cells. Gap junctions, understanding their regulation, as I said, has broad implications, especially because they're expressed in all tissues. For example, in highly excitable cells, such as cardiomyocytes, they are important for maintaining synchronous rhythmic contractions of the heart. When we look at non-excitable cells, such as epithelial cells, they've been shown to be involved in metabolic coupling and homeostasis. Next, we want to look at gap junctions in pathology. Gap junctions have been shown to be rapidly remodeled and even lost under stress. Going back to the heart, it has been shown that this can lead to arrhythmias and even sudden cardiac death. Looking at cancer, they have been shown to be both suppressive and oncogenic. So of the 23 connexins in the human body, connexin 43 is the most ubiquitously expressed. The gene name is GJA1, and it is composed of the single coding sequence and a variable 5' UTR. Now, canonical understanding of translation is that ribosomes and initiation factors bind this 5' cap and complete translation. For the GJA1 gene, this produces the 43K protein. Now, what's really interesting about GJA1 is it undergoes this process called alternative translation. What that means is that this single mRNA can produce proteins of different lengths. So ribosomes can actually bind in the middle of this coding sequence and produce shorter proteins. Here we have identified GJA1 20K, and I'm highlighting that because that'll be talked about in my project, and it is the most abundantly expressed isoform. So all of this background information led to the overarching question of my research, which is how is this translation of GJA1 regulated? So translation of GJA1
promotes the formation of gap junctions. I'd like to turn your attention to this figure here on the right-hand side. And if you look at the left side of this figure, you can see a single GJA1 mRNA producing both 43K and 20K proteins. In the Golgi apparatus, that 20K helps promote the formation of hexamers, which ultimately become gap junctions at the cell border. Now, on the right-hand side of this figure, we can see that TGF-beta stimulation or hypoxia can alter this internal translation. So we get a reduction or absence of this 20K protein, leading to a reduction in the number of hexamers formed in the Golgi apparatus, and ultimately leading to fewer gap junctions at the cell border. In addition, the Smith lab has previously shown that stress results in truncation of that variable 5' UTR. So here we can see in this schematic the 5' UTR, the coding sequence is over here, and they have identified a long, medium, and short UTR. This is shown in the RNA race data here in the middle of the slide, where we can see each arrow identifying those 3 UTRs. And what I want you to take away from this slide is that we have the long UTR here in blue under the control situation, but under TGF-beta stimulation, that is lost, and we get these medium and short UTRs. Now, what this data is showing, it's a Western blot showing that loss of the length of the UTR alone is enough to reduce the amount of 20K being produced. So here we have quantification of that Western, and we can see that the medium and short UTRs are significantly less in terms of their 20K versus 43K production. Next, I'd like to transition to IMP or RNA binding proteins. We're looking at these because they've previously been implicated in mRNA localization. We're looking at IMP1 because previous work in the Smith lab has shown that it promotes that 20K translation. More broadly, it has also been shown with other genes to affect mRNA localization, stability, initiation, and apoptosis. IMP2 and 3 have been linked to cardiac biology, IMP2 in cardiac development and hypertrophy, and then IMP3 in neonatal heart tissue. So all of this information leads to 3 questions that identify gaps in knowledge that my project is addressing. First, we want to know, does mRNA localization impact translational readout of GJA1 to affect gap junction formation? Second, do GJA1 mRNAs comprising of those different 5' UTR lengths localize to different parts of the cell? And third, do RNA binding proteins IMP1, 2, and 3 co-localize along with GJA1? So what do I mean with mRNA localization? Localization means looking at the mRNA in different locations within the cell. So localization historically has been studied in highly polarized cells, such as neurons. And in this image here, you can see a schematic of 3 different types of localization patterning. Now, localization can infer some benefits on a cell. It can increase energy efficiency. It can ensure that proteins are acting in the correct location within the cell, and it can allow for a higher concentration of a specific protein within a specific part of the cell. So the overall hypothesis of my project is altered GJA1 mRNA localization during stress limits internal translation of GJA1 mRNA. This hypothesis was broken down into 3 specific aims. The first, we investigated GJA1 mRNA localization during stress. Second, we looked to determine the role of those variable 5' UTR lengths in the GJA1 mRNA localization. And third, we tested the role of those IMP RNA binding proteins to look at their localization with GJA1. Going over methods, so we used NMUMG or mouse mammary epithelial cells for this project. And all 3 aims were interrogated using confocal fluorescence microscopy and GJA1 RNA fish. I'm going to go over the fish protocol in the following slide, but this fluorescent microscopy will allow us to look at the visual distribution in a 3D way of that mRNA. To look at the changes during stress, we expose the cells to hypoxia or stimulation with TGF-beta. To look at the different 5' UTR lengths, we ectopically introduce GJA1s with those 3 5' UTRs. And then to look at the co-localization of those RNA binding proteins, we co-stained cells with antibodies against IMP1, 2, or 3. So the FISH protocol, as I previously stated, allows us to look at the visual and spatial distribution of the GJA1 mRNA. How it works is it fluorescently tags those specific mRNAs. So we start out with cells fixed with PFA. We add those fluorescent probes that are sequence specific to the GJA1 mRNA. And this is a highly specific process. About 30 of those probes bind to each individual mRNA. We then stain the nucleus with DAPI and collect images on the confocal microscope. The output of those images is then analyzed through a program called ImageJ. So here I have a representative image. This is a picture from the confocal microscope, and you can see the individual cells here. And what we start off by doing is outlining cells of interest, and then the program will identify each of those fluorescent puncta. So each of those little fluorescent dots are individual mRNAs. So that program will provide us an output of both the cell area and the number of those fluorescent foci. So going back to the aims of our project, we utilized all these methods to look at localization changes during stress. So again, we used both hypoxia and TGF-beta stimulation to interrogate this aim. This work is building off of previous work done by the Smith lab that showed 24 and 48 hours of hypoxia reduces the amount of 20K to 43K translation, as you can see the significant difference there. So here are some images we've collected. On the top row, you can see normoxic conditions. On the bottom are hypoxic. On the left is vehicle. And then we also looked at ISRIB, which is a stress response inhibitor. So the big takeaway here is if we're looking at the spatial distribution of each of those green fluorescent GJA1 mRNAs, we don't see any change in the pattern of their localization. And what it looks like they're localizing to is more of a foci pattern, as you can see in the cartoon up in the upper right-hand corner. Additionally, when we ran that ImageJ software, we were looking to see if there was a change in the number of foci over the area of the cell, and we found no significant difference across the 4 conditions. Next, we looked at TGF-beta stimulation, both at 24 hours and then a longer 48-hour. And again, we don't see any change in the pattern of those green GJA1 mRNAs, and we don't see any difference in the number of foci per area of cell. Next, to look at the aim 2 of my project, we looked at those different 5' UTR sequences. If you remember, this figure was on a previous slide. We can see here our long, medium, and short 5' UTRs. And we accomplished this by ectopically introducing those different UTR transcripts into GJA1 knockout cells. And so here are some examples of our findings. You can see on the left-hand side, we have the results of our long UTRs, our medium, and then on the right-hand side, we have short. Now, it's kind of hard to extrapolate exactly what's going on here, but what we can tell is that the short has a much brighter fluorescence than the other 2 long and medium UTRs. So this could be for a couple of different reasons. One, that RNA could just be more stable, or that mRNA could be localizing to something called stress granules, which are collections of rough endoplasmic reticulums installed pre-initiation complexes within the cytosol of a cell when it's under stress. So the lab is currently working on something called a TET inducible system to help control the amount of mRNA being expressed so that hopefully we can correct some of this overfluorescence and get a more concrete visualization on that localization patterning. Next, for aim 3, we look to test the role of those IMP RNA binding proteins and if they are co-localizing within the cell. So we utilized the FISH protocol again. We had fixed cells tagged with those FISH probes, and then we also added fluorescent antibodies, specifically targeting either IMP1, 2, or 3. We then stained with DAPI and collected images on the confocal microscope. And what we're looking for when I say co-localization is these red and green dots together, meaning that an IMP1 and a GJA1 are found together within the cell. So here are some of the images we have collected. IMP are all of the red dots and GJA1 are the green dots. We have IMP1 here in this column, IMP2 and IMP3. And then this bottom row is just a zoomed in image of these upper pictures. And what we're looking for are these little green dots around the little red IMPs. through an analysis software, we were able to extrapolate that, approximately 27% of these IMPs, at least IMP1, is co-localizing with GJA1. And while we found some co-localization across all 3 of the IMPs, IMP1 had the most significance. We took that finding a step further and looked at IMP1 knockdown with siRNA. And what we found is if you remove IMP1, that alone is enough to reduce the amount of GJA20K that's produced. Next, kind of combining AIM3 and AIM1, we looked to see if TGF-beta stimulation would alter that co-localization. And so here we can see a similar image. And what we found through analysis is that TGF-beta stimulation causes a significant reduction in that interaction between GJA1 and IMP1. So just to summarize all of those findings, for AIM1, we were looking at mRNA localization under stress and found that the different conditions cause no change in the number of foci within a cell under TGF-beta stimulation or hypoxic stress. But overall, the mRNA appeared to localize in a foci pattern. Next, looking at those different UTR lengths, we found that there might be something different going on with the truncated or short UTRs, potentially to stress granules, but we're hoping to do more investigation with that in the future. And then AIM3, looking at those RNA binding proteins, we did find that all 3, IMP1, 2, and 3, co-localized with GJA1, while IMP1 displayed the most significant co-localization, but that co-localization was reduced under these TGF-beta stimulation conditions. I'd also like to point out some ongoing work. While all of the previous work was done on fixed cells, we would also love to collect data on live cells, and that would allow us to track the same cells and the same mRNA over a period of time. So if I'm happy to talk about this at my poster later today. I'd like to mention that this work was presented at the ASCB conference in Washington, DC in December. I would like to give special thanks to Dr. Smith, my PI and mentor throughout this project, Dr. Zietz, who was really essential in all of the hands-on work in the lab, and of course, all the other members who gave support throughout this project, and of course, Dr. LeConte. Thank you.
Great job, Ellen. And we're open for questions.
Oh, again, Ellen, fantastic. I mean, what a thorough study, really impressive. I'm just curious about, in addition to the imaging co-localization, did you do any biochemical pull downs to look at complexes using a variety of techniques one might use?
So I haven't done that as part of my project, but I know that's some ongoing work going on in the lab. So that will be investigated. Yeah.
And lastly, can you speculate? I realize it's speculation, but might you want to speculate under any of the pathological processes? You alluded to a few in one of the slides, hypertrophic cardiomyopathy, a few other things, on how this might relate to any of those things in terms of the effects you'd see from stress of any type?
Sure. So ideally, we'd like to translate this work over to highly polarized cells such as cardiomyocytes to see if there are any more significant changes in localization patterning. And so if we can extrapolate where that mRNA is going and if it's producing that 20K at that location, that might give us some indication as to why we're losing gap junctions in things like arrhythmias and sudden cardiac death.
Ellen, that was a fantastic talk.
Thank you.
All right, our next 2 talks are going to be rapid fire format. And so what that means is that we're going to hear from 2 students for 5 minutes, sort of back to back, and then we'll combine the question phase at the end. We'll have about 10 minutes for questions for either presenter. So our first presenter in this format is going to be Kendall Carter. Kendall worked with Dr. John Tuttle from orthopedic surgery, as well as Dr. Vincent Wong from biomedical engineering and mechanics. And she conducted a biomedical study to determine the impact on pull-out strength of a surgical innovation in arthroscopic biceps tenodesis. Kendall.
Thank you, Dr. LeConte. So I'm Kendall, and I'm going to be presenting my project, Biomechanical Comparison of Arthroscopic Suprapectoral Bicep Tenodesis Pull-Out Strength, a Novel Technique. So to start with some background, we're going to be focusing on the biceps brachii muscle, which is located in the upper arm. It has 2 proximal origins and 1 distal insertion. And we're going to focus specifically on the long head tendon of the biceps right here, which is labeled in bold. So this tendon can be injured from chronic overuse or suddenly from a load placed onto the biceps muscle itself. And when injury occurs, there's multiple avenues that one can take for treatment. Typically, if someone fails the medical conservative management, or if they feel physically limited by their injury, then they'll undergo surgical correction with a tenodesis procedure. So a tenodesis is performed in the operating room, and that proximal or injured portion of the tendon is removed, as shown in this figure here, and then it is fixated further down onto the proximal humerus. There's multiple methods that can be used to achieve this fixation as shown in the flow chart, and there's no current consensus on a gold standard for which method to use. So I'm going to draw your attention specifically to one method, which is the interference screw, because this is what my mentor, Dr. Tuttle, routinely uses, and it's used by a lot of orthopedic surgeons. So this particular method has the advantage of strength, but it has a couple of downfalls as well. Some of those are the large osseous tunnel that has to be drilled into the bone cortex to create the tunnel for the screw. And then also that proximal injured portion of the tendon has to be removed prior to fixation. When that happens, it can create some difficulty and uncertainty when the surgeon goes to reestablish the length tension relationship onto the muscle belly that can lead to postoperative complications. So these shortcomings and pitfalls of this particular technique led Dr. Tuttle to brainstorm and come up with a novel method for fixation, which is what led to the creation of my project. So we came up with a novel technique for fixation that utilizes Arthrex's knotless FiberTac soft anchor. So this picture here on the bottom left shows the anchor compared to the tenodesis screw, and it's quite obvious to everybody the differences in sizes of those 2 pieces of hardware. And also the anchor allows for fixation to occur before that injured attachment is removed. So the length tension relationship on the muscle belly never changes. And then also in this picture is the orthopedic button that we utilize to have a surface for the sutures to go around other than just the soft tissue of the tendon. So the specific hypothesis that we were evaluating is that the anchor plus button fixation method would be non-inferior to the interference screw, and we measured that based on biomechanical outcomes. We did an ex vivo study utilizing sheep shoulders. So this here is our model. It shows the humerus, and then it's the flexor digitorum superficialis tendon from the sheep, which is our model of the human long head biceps tendon, and that has previously been used as a model throughout the literature. So this was our control group, the interference screw. And then our first experimental group is the anchor alone. So you can see the anchor through the soft tissue of the tendon, creating the fixation. And then our second experimental group utilized the same anchor, but then in combination with that button that I mentioned previously. These 3 groups were then biomechanically tested using a previously published protocol that consisted of cyclic loading, which was 100 rounds of repetitive loading, similar to doing 100 bicep curls in post-op PT. And then after that was completed, we did load to failure testing. So placing load onto the fixation until it failed or broke. Excuse me. This here shows the results of our study. So the first 2 columns are from that cyclic loading or the repetitive bicep curls. And then the latter 3 boxes are from the load to failure testing. Our primary outcome measure that we were looking for non-inferiority at was the maximum load at failure. Unfortunately, we did not show non-inferiority with our particular study, but as we went through the data a little deeper, we found some interesting results. So the first one is secant stiffness. So this is a measure of the tendon's extensibility during that repetitive load pattern. And as you can see, the 3 means are quite similar for the groups. And we're wanting to show that our novel technique performs similarly to the current standard, which we were able to show for our particular data set. And then second is the normalized yield. So this is from the load to failure testing. So what this tells us is how durable the construct is. So the closer to 1 this value is, the better the construct held up until the point of failure. So you can see for the anchor plus button group, we're actually higher than the interference screw group. So our study showed that the novel technique was more durable. And then for a qualitative measure, we looked at the mode of failure. So you can see in these 3 images here, all three constructs stayed in their cortical fixation, but failed at the soft tissue interface. So you can see that the screw is still intact here, as well as the anchors, but the soft tissue tore around them. So this led us to 4 major conclusions from our study. So first, our novel technique did not meet the non-inferiority parameters that we set forth with respect to the load-it failure. But we did perform similarly in regards to secant stiffness under a situation that simulates rehabilitative loading. And then we also had a higher normalized yield compared to the control group. And lastly, the all suture anchor fixation had adequate cortical fixation, but suboptimal soft tissue fixation. And a special thank you to my mentors and all the staff from VTC and ION that helped with the project.
All right, you'll have a chance to ask Kendall questions in just a minute after we hear from Kyle Nolan, who will be our next rapid fire presenter. Kyle was mentored by Dr. John Chappell from FBRI, and he's going to share with us some fundamental findings he made about a type of cell called pericytes using a 3D electron microscopy technique. Kyle. This one. Yeah. It's good to use it.
Can everybody hear me okay? Everybody good there? Put it on my time. You're the expert. You're the recommendations. All right, I'm assuming everybody can hear me up at the top. Becca's giving me the thumbs up. Thanks, Becca. All right, so good afternoon, everybody. My name is Kyle Nolan. I am a member of the Chappell Lab, and today I'm going to be discussing with you our work in distinguishing ultrastructural characteristics in pericyte phenotypes. So for those of you who may be unfamiliar with this cell type, pericytes, which are seen in green on this image here, are found very closely associated with vascular beds in a number of different organ systems, and they hold a wide variety of different functions. In our study, we looked at tissue from mouse brains, where they hold a very specific function, a very important function, in that they help to form and maintain the blood-brain barrier. Pericytes have been implicated in a wide variety of different neurologic conditions. As an example, Alzheimer's disease is closely associated with decreased numbers of pericytes, and that is associated with a decreased function of the blood-brain barrier and increased deposition of amyloid proteins. Work within the last 5 years has shown that pericytes exist as 3 distinct phenotypes, which have been previously uncharacterized. Work by the Grant Lab worked to characterize them under a number of different forms of data, but one in particular was their morphological findings in light microscopy. The thin strand pericytes specifically have very thin longitudinal cytoplasmic projections along capillary beds, whereas the ensheathing pericytes are a much shorter cell and have much more circumferential coverage along the proximal arterioles in which they're found. The mesh pericytes specifically are an intermediary, both in morphological function or morphology and their localization within the blood vessels. So this is about the time in most talks where people start to think, why should I care about this? And in reality, this cell type has been known for more than 150 years, but it is just within the last 5 years that we have discovered that there are different phenotypes of this cell. So there's a large gap in knowledge in the understanding of the diversity of pericyte phenotypes, with very little known about the morphology specifically and virtually nothing known about the functionality, the specific functionality that is attributed to each phenotype. So to bring it back to our research question, the imaging modality that we used for this study was electron microscopy. By a process known as manual segmentation, we were able to artificially apply color to these images. And after applying this method to hundreds of images within our tissue sections, we were able to derive 3D renderings of our cells of interest. By this, we were able to corroborate our morphological findings with the previously published research to make sure we were, in fact, observing the correct cell type. One area of particular interest was thickness of vascular basement membrane. The vascular basement membrane is indicated here by the arrows in this image, and is an area of particular interest given that it is implicated in a wide variety of different disease states. The vascular basement membrane is also composed of a large number of extracellular matrix proteins, including laminins and collagens for structural support, and integrins and dystroglycans for things like cell-to-cell communication. And when we look at our thin strand and mesh pericytes specifically, there was a very clear trend that occurred when we started analyzing our data, and that the thinnest portion of vascular basement membrane was consistently the interface between the pericyte and the underlying endothelial cell, as seen by the green arrow and the green bars in our data. Now, it's important to note that the vascular basement membrane is a highly heterogeneous structure, and it's important also that our data alludes to the fact that there is a conserved pattern specifically among these two different pericyte phenotypes. Now, when we conversely looked at our sheathing pericytes, we saw an opposite trend. It was not the interface between the underlying cell and the pericyte that was the thinnest, but rather the interface between the pericyte and the overlying brain parenchyma, which is seen by the red arrow and the red data bars. Now, again, this highlights that the vascular basement membrane is a non-homogeneous structure, but it also alludes to the idea that there could be differences in functionality between thin strand and mesh pericytes on one hand and the ensheathing pericytes on another. We also wanted to look at unique ultrastructures among each of our pericyte phenotypes. One in particular is with peg and socket junctions, which is a previously described structure in the literature that acts as a hub for cell-to-cell communication. And we observe these only in our thin strand and mesh pericytes. On the other hand, with our ensheathing pericytes, we described a novel structure of thin vascular basement membrane extensions that extend into the brain parenchyma. Now, because these are previously undetermined or undescribed, we do not really know much about them, but we can propose that their function may be somewhat of an anchor for the surrounding brain parenchyma for the associated proximal arterioles during vessel constriction to help anchor the brain parenchyma to that vessel. So in conclusion, in this study, we were able to show that we can successfully identify pericyte phenotypes using ultrastructural imaging modalities, and we established clear differences in structures among different phenotypes. Our work also highlights the need for an expansion of the fundamental knowledge of pericytes, specifically with that to eventually alluding to their functionality so that we can accurately attribute them to different disease processes. I'd like to quickly thank Dr. Chappell and his lab for supporting me over the last 3 years, and Dr. Michael Fox and his lab for contributions of the data sets for this study. If you'd like to learn more, you can visit our associated publication, or you can visit me at my poster session at the upcoming session. Thank you.
Kendall file is great.
You can stay from the
All right, questions are now open and you can ask questions to either of our speakers.
Hey, Kyle, great talk. I have a question for you. That structure, is it going to have a name? Will it be maybe the Hokie anchor or?
Hokie anchor.
Is it gonna
We
have a
haven't
name?
thought. We haven't thought. We've gone back and forth as to what we're even going to call it. Vascular basement membrane extension or projections, or reviewers get a little finicky with terminology. But the Hokie anchor, I think we can maybe nail that one down. So maybe we'll have to do an amendment to our publication.
I do have a serious question up for Kendall.
Okay.
So in your study, all of the anchors, when you tested them to failure, they didn't fail at your bone anchor interface. They failed in the soft tissue. So my question is, clinically then, aren't they all going to be clinically the same?
Yes, they would be clinically the same, but from our results at the load to failure, they were failing at different magnitudes of load. So the control group, the tenodesis screw, withstood a much higher maximum load before the failure occurred than the anchors.
But they weren't failing at the site of the bone interface, right?
Correct.
They were failing at the soft tissue interface.
Correct.
So what was different between the groups, how they were secured to the soft tissue?
Just whether it was the anchor or the tenodesis screw itself. It was just the method of fixation was the difference.
But didn't the tendon pull through the suture?
Correct.
And the anchor stayed in the bone?
Correct.
So they all failed at by the same mechanism.
Mm-hmm.
So what's your explanation for why they failed at different loads, when in fact the thing that you were testing was maintained in all of them?
Gotcha. I understand your question. So if you think back to the images that I showed, the tenodesis screw had a much larger surface area of the tendon that it was secured around, that the
Okay.
thread of the screw actually came in contact with, whereas the anchor had a smaller area of contact. And that is going to lead the future of this project. So we're going to try to figure out a way that we can create that anchor and button system to have a better surface contact with the soft tissue itself so that it doesn't fail as quickly.
Gotcha. Thanks. Great job, both of you.
Thank you.
Hey, all. Is this on? Okay. Good job. I have a question for you, Kyle. I may have missed it, but what is the significance? So it seems one of your big results is that at the areas where there's overlap between the pericyte and I think the vessel wall, there's a thinner basement membrane. What could be the significance of that?
Yeah, it's a great question. So that's kind of alluding to the possible differences in functionality. So there are a lot of different extracellular matrix proteins that make up the vascular basement membrane, some structural, some cell-to-cell signaling. And I think kind of what we started to allude to in our thinking of this is that the thinner the vascular basement membrane may point more towards a cell-to-cell communication type function as opposed to a structural one, especially given that a lot of these cell-to-cell communication proteins are a lot smaller in their size, a lot of them smaller than 200 kilodaltons, as opposed to some of these structural proteins that can get up to always upwards of 800 kilodaltons. So it makes sense that the smaller cell-to-cell communication proteins would fit into that smaller space. And then given just the smaller distance that communication would have to occur, it's a little bit more efficient. So we believe that the thinner interface alludes more to a cell-to-cell communication type function as opposed to a cell structure function that a wider vascular basement membrane would perform.
Interesting. Sorry, just one follow-up question. So, oh boy, what was it? Okay, so these parasites, you're studying a lot of what you study has to do with the blood-brain barrier. Does this mean that is there cell-cell communication in what kind of cell-cell communication would be kind of facilitated by a thicker area of parasite?
Sure. I can't really speak to the type of cell-to-cell communication because that wasn't really the scope of our study, but I think one of the important things that even came up yesterday as we were rehearsing this is that these are very conserved structures. And when we're talking about the thickness of this vascular basement membrane, we're talking on the scope of less than a micron. So any change to that is going to disrupt that interface of cell-to-cell communication. So I can't really speak to how it happens, but overall, we believe that because it's thinner, that it's going to help facilitate that.
Thank you.
So I had a quick question for both of you. Kyle, just a comment, you can comment on the comment. It seems to me you're really strongly positioned to do an unbiased kind of a cluster analysis along multiple dimensions of all these parameters you measured. So you showed us, the comparisons for each parameter. You could take those together and do as I said, a cluster analysis. And what I'm really getting at is whether there are transitional phenotypes. You see these three different groups. Might you catch some in the middle that are in a dynamic state, for example?
Yeah, and that's one of the areas of future research that we would be interested in the future, is that of how do these adapt through embryogenesis and through the development of these vascular systems. Parasites are highly involved in angiogenesis as well. So how does a parasite maybe form or morph in between these different phenotypes? Is it a fluid response or are there intermediate phenotypes as well? How are those derived? And I think that would come from studies in a lot younger of a mouse population as opposed to the adults that we were using.
Okay, thanks. And Kendall, I just want to ask you, you may have said, and I may have missed it, were the experiments done on, these were sheep bones, I think, at room temperature, the drilling and the implants, or at physiological temperature?
So it was frozen tissue that was then thawed to room temperature for the study to be, or for the fixations to be performed. And then for logistic reasons, we refroze them and transported them to Blacksburg for the biomechanical studies. And they were thawed and done with ice baths.
So I was just curious, if you were to warm them up to physiological temperatures, might there be a different response at that something that would be more related to what's happening in vivo, for example, or maybe not. I don't know.
Yeah, that's a really good point. Through the process of developing this study and coming up with the protocol that makes the most logistic sense, we had a lot of questions about the temperature and how many times we were going to freeze and thaw and freeze and thaw. And the answer that made the most sense at the end of the day was that since we were comparing three groups that were all undergoing the exact same conditions, that we were comparing apples to apples, no matter how many times we did it, as long as they all underwent the same process. But that's a really good point about the temperature.
I'm going to sneak in with one more question. For the maximal loading, so you showed the cyclical was about the same between the fixations, but the maximal loading was not. Is there a minimal clinically significant maximal loading that you're aiming for where it might not come up to the same level as this group?
Yeah, so that is why there is no gold standard on which fixation method we utilize, is because we don't have a really good understanding of what a time zero biomechanical study would translate into clinical significance. Because if you think about real life, these patients are going to undergo healing and they're not going to do 100 bicep curls the second that they come out of their surgery. So no, is the answer to your question, but we did an extensive literature search about the common loads at failure and came up with a number of newtons that we were comfortable with from the literature search and from Dr. Tuttle's clinical expertise. And that's where we developed our non-inferiority limit.
Great. Thank you for both of you.
So the hardest part of Kendall's study was actually finding a freezer for sheep shoulders. I'll just say that they're kind of big. Okay, so that's the end of our first oral presentation. Students, I want to remind you that there are QR codes all over the place. We want you to all vote for awards for posters. So you can vote for up to 3 posters for each of the 7 categories. There's also a link in Canvas, but the QR codes are probably easier. Let's see. So we will see you back here at 3:30. And thanks, everybody. All right, we're going to go ahead and get started with our second oral presentation session. We're going to let everybody come in and sit down. Welcome back. A lot of good discussions going on in the poster sessions. Thanks everybody for your engagement. It was great. We're going to hear from 5 students for this session. These are the remainder of our students who've been recognized with letters of distinction for research scholarship. And if you remember, these are selected by our faculty mentors and evaluators who look at our students' writing and their oral presentations that they give between years 3 and 4. And then those letters of distinction are selected based on the overall quality, significance, relevance, innovation, and clarity of the findings. And so I'm excited to introduce our first speaker of the session is going to be Katie Brow. She worked on an important implementation science collaboration with her mentors, Dr. Shannon Armbruster from obstetrics and gynecology, and Dr. Samantha Harden from human nutrition, foods, and exercise. So Katie's project examined how to optimize the development of a lifestyle modification program for endometrial cancer survivors. Katie? You want this one? Oh, you can hold it, Mike. Yeah.
Thanks, Dr. LeConte. Hi, guys. My name is Katie. I'm excited to share with you guys a little bit about our foundational work for creating a lifestyle modification program for endometrial cancer survivors. To give a little bit of background, obesity, which we define as a BMI over 30, has been implicated as a significant risk factor for several different types of cancer. And out of all those obesity-related cancers, endometrial cancer is the one that's most strongly associated with a rising BMI. Additionally, obesity also persists into the survivorship period. Over 70% of endometrial cancer survivors are overweight or obese, and survivors with higher BMIs do die at a higher rate than their non-obese counterparts. And importantly, obesity is also associated with significant quality of life issues during the survivorship period. However, 5 years after their diagnosis, the most common cause of mortality in endometrial cancer survivors is cardiovascular disease related to their underlying comorbidities. And this is important in a public health way too, because endometrial cancer is already the most common gynecological cancer and is increasing in prevalence. So in light of the relationship between obesity and significant comorbidities in the survivorship period, the American Cancer Society does recommend guidelines for physical activity in the survivorship period. They recommend that adults get 150 to 300 minutes of moderate intensity or 75 to 150 minutes of vigorous intensity each week. And whether or not patients are informed of these guidelines and whether or not they have the means or the support to actually achieve this goal is largely unknown and not studied. So this is where the strategies of implementation science come into play. So shout out to Dr. Parker, our queen of implementation science. And since medical students love spaced repetition, I'm going to provide the definition of implementation science again. So the NIH defines implementation science as the study of methods to promote the adoption and integration of evidence-based practices, interventions, and policies into routine healthcare and public health settings. So essentially, we have all these wonderful programs that do really well in a research sphere. We know that these interventions have shown to improve like weight loss, quality of life, physical activity, diet, but whether or not these interventions are performing in the real world, in the quote unquote real world, in those communities that we actually want to benefit is largely unknown. So the goal of implementation science is to kind of close the gap between what's being done in the research world and what's being done out in the real world. In this project, we employed one of the most important and widely used conceptual frameworks in the field of implementation science, which is the RE-AIM framework. There are 5 components of RE-AIM, which we'll walk through now. The first is reach, which is the absolute number, proportion, and the representativeness of the individuals that we're actually trying to get to participate in these interventions. The second is effectiveness, which is the impact of our program on our desired outcomes. And that also includes potential negative consequences. Adoption is how many people do we actually have available to deliver our intervention. Implementation is at the setting level, is the program being delivered as it was intended? And at the individual level, are our participants actually using the intervention strategies? And finally, maintenance. And maintenance is all about sustainability. So how much is this program being institutionalized into community service programs? And then also, are our patients seeing results even after the program ends? So the objectives for our study primary, we really want to identify the barriers to delivering a successful lifestyle intervention program, because as of right now, there isn't a program specific for endometrial cancer survivors at Carling Clinic. And secondary, because this is a largely underserved, understudied population, we really wanted to learn a little bit more about them. So we looked at quality of life issues, patient knowledge of the relationship between obesity and endometrial cancer, their physical habits, as well as the impact of COVID-19 on physical and mental health. For our overview of methods for patient recruitment, we had 2 kind of strategies. One was an email survey to a previously established database of endometrial cancer survivors, and we also recruited patients in clinic. Our second kind of foundational work was a literature review where we looked at all the different interventions that are currently available for survivors of endometrial cancer. And we evaluated all of them in terms of their acceptability, appropriateness, and feasibility. And we ultimately selected 4 different interventions that we used to kind of be evaluated by our focus groups. Our initial survey consisted of 6 different components: demographics, health behaviors, their exercise and their body weight prior to their cancer diagnosis, as well as their body and quality of life issues after their diagnosis, just general interest in an intervention at Carling Clinic, and then finally opportunity to become enrolled in those focus groups. We had 2 different opportunities for qualitative data collection. The first was the focus groups, and we conducted these virtually, both in light of COVID-19 and also because a lot of our patients kind of live far outside the Roanoke area, and we didn't want geography to be a limitation to participating in this study. Each focus group session consisted of 2 to 5 participants. We also conducted individual phone interviews to achieve our data saturation, and those phone interviews used scripts based on our focus group data. Finally, we had a follow-up survey that was delivered to those who participated in our focus groups, and they used the same strategies that we implemented in our focus groups to evaluate those interventions that we identified in our literature review. And finally, in terms of data analysis, we both had qualitative and quantitative data of the initial survey, our focus groups and interviews, and then the follow-up survey data. For our focus groups, we decided to use a novel methodology called the brainwriting premortem. Again, because we don't have an intervention that exists at this time, and we really wanted to develop an intervention that included our stakeholders from the ground up, we wanted to ensure that their input was the foundation for the creation of this program. And this methodology has been shown to more effectively engage those stakeholders and identify barriers more efficiently than a traditional brainstorming session. So we would basically give our participants an example program. It's a 6-week program. You meet once a month and you do all these different things. And then after introducing the program, I basically tell them to set the stage. I want you to imagine that this program has failed. Nobody likes it. It's not getting the results that we want. And everyone's really unhappy with this program. And then we ask them, why do you think this program didn't do so well? And then for the scripted part, we had questions related to each component of RE-AIM. So reach, why did this program not work for you or other survivors? Effectiveness, why are we not seeing the outcomes that we want? Adoption, who do you want to see actually delivering this intervention? Implementation, what are the costs? What are the resources that we need? And then how long should this program even be? And then finally, maintenance. So why would this program not work for you in the long term? In terms of some of our results, we had a final survey response rate of about 20%, when we included those that were recruited over email and also in clinic. We completed 5 virtual focus groups with a total of 13 participants and 3 individual interviews. And we reached out of saturation after the first individual interview. And then 10 of the 13 people who participated in the focus groups also completed a follow-up survey. In terms of our demographics, it's important to note that there were not any statistically significant differences between our eligible participants and the survey respondents. We feel confident that our survey was representative of our larger patient population. And this patient population is mostly white, older women with an average age of about 60, with a higher BMI around 40. And then they also mostly had stage 1A or 1B disease that was surgically managed, which is important when we think about quality of life issues. For our qualitative analysis of our focus groups and the individual interviews, we employed an inductive coding approach, which basically is a ground-up approach, deriving our own codes from our data. 2 individual coders, myself and another member of the research team, created a code book that ultimately resulted in 54 individual codes, which is our smallest piece of qualitative data, 34 categories, 18 sub-themes. And then for the overarching themes, we coded according to each component of REAIM. We also developed 2 new themes, program components, and then issues related to cancer treatment or survivorship. So as an example of how this code book works, this is a real quote from one of our focus groups. And they said, "A weight loss program is not a selling point, as most of us have done that route before. I'd be more interested in a healthy eating program." So as an example, that code would be making lifestyle changes. The category would be scope or goals of the intervention. The sub-theme was being healthy versus losing weight, falling into the overall theme of effectiveness. So we independently coded all of the transcripts from all our data and then compared for intercoder agreement. When we did this, we found discrepancies in about 16% of our codes. Of these, about 13% we identified as minor discrepancies, meaning they varied on code, category, or sub-theme, and almost 3% as major, which means they differed on the overall theme. All these discrepancies were resolved between the 2 coders. For our results, these were the major takeaways within each theme from our thematic analysis. So REACH was really all about the barriers. So time and resource costs, like how much is this going to cost to participants? How much is this going to cost to the system? And then also access for our rural populations. The effectiveness, the scope, was really about scope, and a lot of them was really expressed over and over that they didn't want this to be about losing weight. It was more about gaining health. Adoption was all about the program facilitators, those who were actually delivering the intervention. They had a lot of thoughts about who should be doing this. They really felt that they should be experts, but also really empathetic and enthusiastic and approachable. Implementation was all about logistics. So things like session length, frequency, the mode of delivery, whether that's virtual or in person, that all would really influence someone's decision to participate. And then finally, maintenance was all about sustainability. So they really expressed that they wanted the result to be sustainable, resilient to life events. In terms of our 2 other new themes, program components was all about the facilitators. So opportunity to interact with other cancer survivors, and that community building really came through, and it was a really important theme for us. And then cancer survivorship, this was an interesting discussion that came about organically a lot in a lot of our focus groups, because a lot of them had never had an opportunity to meet other survivors, and they were able to kind of talk about, their frustration with perceived lack of transparency going through this process, or just not knowing where to go for accurate information. In terms of our quality of life, this was another important objective for us. We assessed quality of life using a validated tool called the Functional Assessment of Cancer Therapy, specifically for endometrial cancer survivors. A higher score on this scale is correlated with higher reported quality of life. There are 5 subscales: physical well-being, social and family, emotional, functional, and then quality of life issues specific to endometrial cancer. So things like experiencing early menopause, vaginal discharge, pelvic discomfort, things like that. Our lowest scores for our survivors fell into that social and family well-being. So having those support systems, emotional well-being, concern about illness or coping skills, and then functional well-being, which is, have they accepted their illness? What's their sleep like? Are they enjoying life? And our total score was an average of about 136 out of 172, which is pretty consistent with other studies. We were also very interested in understanding whether or not survivors actually know those guidelines that we're supposed to be educating them on. And when we asked them to correctly identify the guidelines. Only 27% of respondents answered correctly. And then when they are presented with the correct guidelines and asked about their confidence in being able to meet those guidelines, pretty much across the board, no one reported confidence. And interestingly, there was a statistically significant difference in BMI. So those with a higher BMI were more likely to report less confidence in meeting those physical activity guidelines. In terms of preferred types of exercise, there wasn't really a difference before and after cancer diagnosis. They all really preferred low impact activities such as walking. And then of course, the impact of COVID-19. So most respondents already reported low confidence in meeting physical activity guidelines, and during the COVID-19 pandemic reported even less confidence. They also reported decreased rates of physical activity, changes in diet, and decreased quality of life. So in conclusion, our main takeaways and next steps. This study was an important first step in understanding a largely underserved and understudied patient population. Respondents definitely prefer interventions that prioritize overall well-being, not necessarily weight loss. They really prefer low impact activity and survivor empowerment. And again, that community building was very, very important to them. Most survivors don't actually know the physical activity guidelines, even though we're counseling them frequently throughout their treatment. And a higher BMI is associated with lower confidence in meeting those guidelines. The COVID-19 pandemic certainly had an impact on their physical well-being and also their mental health. And then in terms of the next steps, I'm excited to report that we did complete a proof of concept study. And then right now we're actively recruiting for a larger clinical trial for our intervention. So first, I would really like to recognize and thank the survivors who took the time to participate in this study. Truly, for me, the most gratifying part was being able to get to know them and watch them build this community and become more empowered throughout the process. That was just really excellent to see as a medical student. And then also, I really want to thank all my wonderful mentors and other members of my research team. I couldn't have done it without you guys. Thank you so much.
Fantastic talk. Do we have any questions?
Awesome study, Katie. I think it's really interesting comparing like physical activity with cancer, especially. It's obviously has a lot of applications. I was wondering with the graph where you were showing like the confidence based on BMI in physical activity. Did you stratify that at all by the types of physical activity in terms of like, did you see if patients were like more likely to be confident with walking or other low impact activities versus like running or swimming or something like that? Or like, and if you didn't, do you think that that could have any value with sort of approaching patients with activities that they might be more confident in doing or doable for them?
That's a really excellent question. Yeah, this was just looking at whether or not they were confident in meeting the guidelines, not necessarily like how they were meeting the guidelines. So that would be an interesting question. But for the most part, I think most of them like really preferred that like low impact activity. I think it could be related to like their reported functional well-being and things like that. But that would be an interesting question to ask. Like, would you be more confident making the guidelines if it was like yoga versus just walking? And yeah, it's a good question. Yeah, thanks, Gabriel.
Great talk. So when you were going over their kind of quality of life statistics, and it was showing that they felt discrepancies most in those kind of social, emotional, functional, do you think it would be worthwhile to maybe try to pair them up with their primary partner or caretaker and survey that person to see if perhaps they're having some fatigue, some caretaker fatigue, and designing interventions that maybe pair them together to go through?
Mm-hmm. That is such a wonderful question, because actually the trial that we're doing is using a program called FitX, in which the survivors recruit family members or people that are close to them to participate with them in the program. So we're able to get data from both sides, and they have their support people going through it. So that's the goal, is to have support for both of them.
I have a question. How do some of these quality of life indicators compare to other groups of cancer survivors?
Yes, that's a great question. So the functional assessment of cancer therapy, they have a general questionnaire that you can also use. And then then it can stratify based on other types of cancer as well. And from the data that I've seen, it's pretty consistent across all boards. So the general survey is the first 4. It's only that last section that's specific to endometrial cancer survivors. And from the data that I've seen, this is pretty consistent with other types of cancers too. Yeah.
Fantastic. Great talk.
Thank you.
I forgot to mention Katie's mentors, Shannon Armbruster and Samantha Harden, are both involved in the iThrive program. So Shannon Armbruster is an iThrive scholar. So it's great to have some of that coming into the medical school. And we've got Brandon Gangina is working on the FitX work with this team as well. So it's a big group effort. Our next presenter is Catherine Harden, who worked with Dr. Steve Polzing and Dr. Greg Hooker, both from FBRI. And so this project is going to take us back to the realm of basic science. And Katie examined the ultrastructure surrounding the cardiac intercalated disc and its role in calcium handling. Katie.
Can you all hear me? No, maybe not now. Yeah, okay, great. All right, hello everyone. My name is Katie Harden, and I'm going to be taking you on a deep dive into the heart, down to the nanoscale level, but I promise I have a lot of pretty pictures to go along the way. So we're going to be starting off by talking about cardiac arrhythmias, which are defined as the abnormal electrical conduction. Why do we care about arrhythmias? Well, they've been identified as one such etiology of sudden cardiac death, of which there are 4 to 5 million cases of every single year. Now, cardiac conduction is defined as the transmission of electricity from cell to cell. Now, when we look at this tissue slice of cardiac tissue, this dark pink squiggly line here, that's the intercalated disc, which is the junction between two adjacent cardiomyocytes. Within the intercalated disc, there are a variety of very important structures and proteins. One of which is the gap junction, which we heard a lovely overview from Ellen earlier. And specifically, the connexin 43 isoform is very prevalent within the ventricles. And so we can just go ahead and wrap up this talk, right? It's the gap junctions. That's the whole story with cardiac conduction. Well, while they are a key component of conduction velocity and conduction propagation, they are not the sole determinant of it. We're going to take a look at this electron microscopy of a cardiomyocyte. And when we zoom in, we have now a dark black squiggly line, which is the intercalated disc. We zoom in even further, and now we can see all of those different structures that we were just talking about. So we've got our gap junction bordered in green, our mechanical junction bordered in blue, and then we have this structure called the perinexus, which is bordered in orange. The perinexus is a 100 to 200 nanometer intermembrane cleft that is always adjacent to connexin 43 gap junctions, and it's been shown to play a key role in conduction propagation. Dr. Rob Gordy was actually the first one and members in his lab to identify the perinexus and look at different structures within that region, specifically sodium channels, and find that when you alter concentration of sodium, you can alter the intermembrane distance of the perinexus. Continued work in the Polzing lab found that when we alter other electrolyte concentrations, for example, calcium, when you decrease extracellular calcium, you can increase the width of the perinexus. And this is bad. We can decrease conduction velocity in this case, and it can result in arrhythmias. They also found that actually when you also have widening under certain states of cardiac stress, you can actually preserve conduction velocity, and this can be cardioprotective. So we're wondering what's going on here. And it makes us ask the question, do myocytes localize calcium to modulate perinexal width? We first have to talk about calcium. We've brought this up here. Why is it important? Why do we care about it? The big thing is that it's critical for heart contraction. Now, typically in medical school, we all learn about that in the T tubules. That's where it's typically found. We can see it here. It's highlighted in the green here. And its primary function is to bring calcium into the cell. Other things where calcium is important in the heart is that these adherens junctions like N-cadherin are calcium dependent to work. And then lastly, it's also regulated by adrenergic responses. For example, those states of cardiac stress that we talked about earlier. Now, one type of calcium channel are L-type calcium channel, and then specifically CAV 1.2. And this is our primary target in this study. And we're looking at this because it is a predominant isoform in cardiac ventricles. And then also it's the primary target for that adrenergic signaling. Now, what do we know about CAV 1.2? So again, we talked about it's in the T tubules. And everyone likes to look in the T tubules. Everyone always forgets about the intercalated disc. It's on the ends, they just kind of forget about it. So to our knowledge, there hasn't been a quantification of CAV 1.2 in the intercalated disc in whole tissue. We also want to know, in the prior studies, extracellular calcium alteration affected perinexial width, but how does actually altering that channel function affect perinexial width? And this brings us to our hypothesis that there is a subpopulation of CAV 1.2 in the intercalated disc, and that alteration of it does modulate perinexial width. Our first specific aim was to quantify the presence of CAV 1.2 channels within the intercalated disc. And to do this, we had to pick different immunofluorescence candidates. So we used N-cadherin as our intercalated disc reference structure. We then used connexin 43 as our perinexus reference structure, because if you remember, the perinexus is always adjacent to connexin 43 gap junctions. And then lastly, we just had a whole slide on it. Where's our CAV? So that was our third one, CAV 1.2. For our microscopy, we started with confocal imaging, and this is because it has the spatial resolution to allow us to identify CAV 1.2 within the intercalated disc. And here we can see in cyan, that's the CAV 1.2. That bright pink magenta is N-cadherin, and then the yellow is connexin 43. You can use a super resolution type of microscopy called SORA to zoom in on one of these intercalated discs, and you can see those structures a little bit better. The Nikon software allows us to take the Z-stacks from that confocal microscope and make a 3D reconstruction into this blob here. But we're going to take a little bit better look at the blob now and really appreciate where the overlap of CAV 1.2 with those other colors, the magenta and connexin 43, is occurring. We're going to zoom in and see a really nice, you can see that cyan color is really embedded within the magenta. And this is just a really nice visual representation of CAV 1.2 being localized to intercalated disc structures. Now, we are numbers people. I like numbers, so let's talk about the numbers. The Nikon software can allow us to look pixel by pixel, and you can set a threshold that the immunofluorescence passes for each individual antibody. And so that's an example here. We do that again for a different antibody. And then we look at what pixels have both a co-occurrence of those two antibodies. Now, we also had to define our intercalated disc. Was it just N-cadherin? Was it N-cadherin and connexin 43? And we decided to look at both of those. And that we found that all of this CAV signal, all of this cyan color, that 6.2% of it had an overlapping co-occurrence with N-cadherin, and 9.4 had a co-occurring with the connexin 43 added to that. So we're not stating that all of the CAV is in the intercalated disc, but this is showing us that there is a discrete subpopulation associated with intercalated disc structures. Now, yes, confocal microscopy can help us understand is CAV in the intercalated disc, but STORM can allow us to figure out the distribution of CAV throughout the intercalated disc. Are there structures in certain areas? Things like that. And so Dr. Smith and his lab have been instrumental in helping us through this process. So here we can see a wide field microscopy image of the intercalated disc. Now we have STORM, and each of these individual balls is actually an individual fluorophore from those antibodies, which is really cool. And you can see a nice overlay of CAV in our cyan color with our N-cadherin, our intercalated disc band here. So another nice visual representation, but show me the numbers. So we have a collaborator at Ohio State, Dr. Viraragavan, in his lab that have a specific cluster analysis actually for STORM. And they look at the clusters of CAV 1.2 relative to the distance from N-cadherin proteins, and found that the peak of those clusters occurs at 50 nanometers. That's really close, but to give you an idea of that, on this scale bar, this is 200 nanometers, so it's not picking up all this stuff over here. So we can really appreciate that we have that cave within the intercalated disc and that there are discrete clusters within there. And then just to note, 64% of those total clusters are occurring at the 50 nanometer distance. So this is great and all. We've identified that there are cave within the intercalated disc, but what does this mean functionally? So that's our second aim, is understanding when we agonize cave 1.2, will that increase perianexal width? And we went about this by doing the Langendorf perfusion. Historically, our lab has used geriatric guinea pigs, and while they're anesthetized, we take out their hearts while they're beating, and so they continue to beat while we submerge them into a physiologic electrolyte solution. We hook them up to a retrograde perfusion cannula here, so that solution is running through here into the aorta, and there's the heart. Once it's in that bath, we can measure a lot of different things like the EKG, the temperature, and then the perfusion pressure as well. This is a pretty drastic intervention that we've just done, so we let it stabilize for 20 minutes. And then we do a 15-minute intervention period with a variety of different things that we're going to talk about. So our first one is our cave channel agonist, which is BK8644. We wanted to have a control, so we used our DMSO as our vehicle control. And then we also wanted to look at further upstream mechanisms of calcium alteration. So this is a beta agonist isoproterenol. And then what would happen when we directly block our L-type calcium channel blockers using verapamil? Now, to measure the perianexal width, we take left ventricular tissue and use electron microscopy. A single user will then outline the perianexus here and run it through our MATLAB script that will take the average perianexal width along this blue line. This has been a validated method in our lab. And here's the results of it. So we have representative images from our control samples and then our BK or our CAV 1.2 agonist treated hearts. And just visually, you can see that's larger. But when we look at the numbers here, we have perianexal width on the y-axis, and then we have our two groups, and this is the average perianexal width for the total of those groups. And we have 15 perianexi for each of the hearts that we take. And we see that there is a significant widening for our BK treated hearts. Now, in terms of that higher upregulation of our isoproterenol and verapamil treated hearts, Dr. Greg Hooker did the experiments for these, although we still did have a single user who analyzed and was blinded, myself, for the analysis of this tracing during the time. And we found that when you add verapamil, the L-type calcium channel blocker, it prevents the widening that occurred with the beta agonist isoproterenol. And this brings us to our conclusion that CAV is located in the intercalated disc and it closely associates with NCADH. That adrenergic stimulation through the isoproterenol increases perianexal width, and that when you have block CAV 1.2, it prevents the adrenergic mediated effect on the perianexus. Our study did have a few limitations. We had a relatively small sample size, although our power analysis did confirm that we had an adequate size. This is a non-human model, although guinea pigs do have closer arrhythmogenic mechanisms relative to mice or rats. So that's why we use them. And then lastly, there is no direct measurement of intercalated disc calcium concentrations. However, this is actually impossible to do in whole tissue. And that is why a lot of the studies to date have been done in isolated cardiomyocytes. So with that, I want to thank my mentors and specifically my primary mentor, Dr. Greg Hooker and Dr. Steve Polzing, as well as all of our other collaborators and the VTCSOM domain staff. And I will be happy to take questions.
Hi, Katie. Thank you very much. Very exciting research. I was wondering if it matters what part of the ventricle you use in your experiments and how you decide.
That is a great question, and one that we actually didn't show the results for, but was part of our original project. And we have a little backup slide here that always be prepared, guys. That you actually, it doesn't matter whether you take it from the base, the middle, or the apex. The perianexal width is all the same for it, and it's not affected by the time difference that it takes to extract those samples from those different regions in the heart. Yeah. Yeah, I think, I spent all that time talking about cardiac conduction in the beginning. And I think that is where we're going forward with. So on my poster, we had some images of conduction velocity studies that Dr. Hooker has been doing and seeing how the effects of isoproterenol and verapamil affects conduction, because that can give us a closer insight into the arrhythmogenic properties. And optical mapping is also just really cool because you can actually map individual action potentials on the surface of the heart. So that's why we had that window there on that picture of the heart at the beginning.
Yeah, very, very nice study. You got me thinking, both a beta blocker and an L-type voltage gated calcium channel blocker would both reduce the effect on the perinexial width. So both alone should be anti-arrhythmogenic, I presume. Is that the supposition?
Potentially, yes.
Okay. So I'm not sure about this, but I thought on the clinical side of things, a beta blocker and a calcium channel blocker generally would not be used together because of potentially being pro-arrhythmogenic when used together. And I wonder if that relates to something outside of the perinexial width effects, or if there's some synergistic interaction of the two on the perinexial width besides what they each do independently.
Yeah, I think that's a great question that I don't have the answer to. I think that would be really interesting to look at the simultaneous effects in future studies as well. Yeah.
All right, that was a fantastic talk, Catherine.
All right, our next presenter is Ali Strauss. Ali worked with our Research Mentor of the Year, Sarah Parker from FBRI and Health Systems and Implementation Science. They worked together to develop a model to evaluate participants' response to simulated opioid overdose scenarios. So, Ali.
Good afternoon, everybody. Thanks for sticking with us. I'm really excited to present today on our project development of a model for the simulation of and participant performance evaluation in opioid overdose response and naloxone administration. I just want to take a moment right off the get-go to just acknowledge that this project has been incredibly multidisciplinary and thank all the individuals for their time and effort to this project. And I want to give special thanks to the whole FORCE team who's collaborated and contributed to the success of this project. A lot of people talk today about teamwork, research being the ultimate team sport, and I definitely agree with that. So just a quick overview. We'll start with some background on opioid overdoses. So it goes without saying that unfortunately opioid overdose is a public health epidemic and one that remains a huge issue for our country. Given the recent increase in opioid overdose deaths, there's some gaps in knowledge that our project sought to address. So in response to this epidemic, overdose education and naloxone distribution, or OEND programs, began to establish across the US. There's over 600 programs that exist today, and research has shown that the distribution of naloxone within communities and the implementation of these OEND programs has been correlated with decreased rates of opioid-related deaths. Now, while the American Heart Association and the Substance Abuse and Mental Health Services Administration both have guidelines for opioid overdose response, few, if any, of these programs actually incorporate, the full curriculum. So this leads us to a gap in knowledge, which is that there are gaps in the training experience a layperson population receives despite the availability of naloxone within these communities. To talk for a minute about the current assessment instruments that exist, there's currently 4 validated surveys, and these are all designed to assess opioid overdose knowledge and attitudes, but none of them actually assess the hands-on skills imperative to an opioid overdose response, like assessing breathing, naloxone administration, and chest compressions. And the OEND community lacks a tool that measures these hands-on resuscitation skills. So there's a need for a detailed instrument with defined process measures for opioid overdose response that can be a standardized tool used in the OEND program evaluation and research. And just to note, I'll be using process measures as a term throughout the presentation. This just is quantifiable steps for completing a skill. So even if we had this instrument that was able to assess hands-on skills, how could we assess it or test it? And simulation is a powerful tool for education, training, and the evaluation of a trainee's learned skills. It provides an appropriate environment to measure skills in a life-threatening situation, such as an opioid overdose. And it's a safe and controlled environment for standardized evaluation and helps to minimize risk while providing a realistic experience. So this brings to the overarching research question, which is how can community-based opioid overdose response training be improved? And our hypotheses are a simulation-based evaluation instrument will identify consistent and replicable features of out-of-hospital opioid overdoses, and that the efficacy of rescuer interventions and naloxone administration by a wide range of laypersons or professional rescuers can be evaluated in this simulation environment. There were 4 specific aims that our project sought to achieve. First, to identify commonly observed and replicable environmental and behavioral features of overdoses for use in the development of simulation. Second, to apply a rigorous process to identify the detailed steps a rescuer should take in response to an opioid overdose in the community. Third, to create a nuanced evaluation instrument specific to opioid overdose and designed to be applied within simulation. And finally, to apply a rigorous and comprehensive validation process to the rescuer evaluation instrument. We achieved this through 2 phases, both will be discussed. Phase 1 consisted of 17 semi-structured interviews with individuals who have expert knowledge of overdose from a wide range of perspectives. This included ED physicians, first responders, OEND instructors who are individuals who teach the opioid education and naloxone distribution courses, as well as peer recovery specialists who are individuals with past opioid use disorder who have gone through treatment and are now trained in opioid overdose response and naloxone administration. So this is a schematic of our recruitment. And the main goals of this phase were twofold. First, we wanted to ask questions about the opioid overdose scene. We wanted to better learn about the setting, the clothing, various bystanders that may have been on scene. We asked questions about what an IV opioid overdose looks like versus what a prescription overdose looks like. And we eventually used the data from this phase of the interviews to develop the simulation scenarios, which I'll discuss in a bit. Secondly, we ask our interviewees questions about the ideal actions that should be taken in an opioid overdose response and how to define those. So prior to these interviews, a thorough literature review was done where we identified some steps in opioid overdose response that's already reported by the literature. And then we use these interviews to build upon that framework. So we asked about the actions that should be taken in an overdose response from their various perspectives, as well as the timing of these various interventions and when they should occur. We then later used this data from this phase to develop our evaluation instrument, which I'll talk about as well. So some analysis and results from phase 1. After we completed our interviews, this data the interviews were transcribed and the data was analyzed using a qualitative analysis software. It was coded by 2 independent coders, and Katie gave us a nice brief introduction to themes and sub-themes that were created from this thematic analysis. So our coders met regularly to discuss the various themes and sub-themes, establish some inclusion and exclusion criteria. And using this framework, it's you reach saturation between 6 to 20 interviews, of which we had 17. From this phase of our study, as I discussed, we did 2 main things. So first, we were able to develop our community-based opioid overdose evaluation instrument. And this consisted of components that were important in a isolated respiratory depression. So when you have an opioid overdose and somebody has a low breathing rate versus an opioid-associated out-of-hospital cardiac arrest. We were also able to develop our opioid overdose simulations. So some results from phase 1, here's some of our demographic data. While in some components of this demographics is homogeneous, we do have a diversity of experience, which was our main goal for this phase. And as I mentioned, we were able to develop our evaluation instrument from phase 1 of our study. So this is a schematic here of our evaluation instrument. In total, we had 15 overarching themes with 60 sub-themes underneath. And as I mentioned a little bit earlier, we decided to create 2 separate instruments because in the piloting phase, it was determined that it was not feasible to have one instrument that evaluates 2 distinct clinical presentations. So we decided to focus on an isolated respiratory depression. And this is the example here. So in this instrument, we have 13 overarching themes as well as a timing component. And I just want to highlight what one of these sections looks like. So for example, in this one, our overarching theme is assessing breathing, and we have sub-themes underneath it that more definitively defines the actions that should be taken under that category. Our second iteration of this instrument is applicable for an opioid-associated out-of-hospital cardiac arrest. This one has two overarching themes with a timing component as well. And again, just to highlight a section, defibrillation with some sub-themes underneath. We did ultimately put a lot of thought and effort into how each of these process measures were weighted, but for the sake of this presentation, I'm not going to get into that too much, but just to note. After developing this evaluation instrument, as well as our simulation scenarios, we were able to move to phase 2 of our project, which involved piloting both of these. So we recruited 49 participants. These included healthcare professionals, laypersons with opioid or substance use experience, and laypersons without. And these scenarios took place at the simulation center across the street. Here's another schematic of our recruitment. And each of our participants went through two different simulation scenarios to kind of correlate with our two distinct clinical presentations. So the first scenario was an isolated respiratory depression scenario in which the only resource available on scene was a Revive kit, which basically includes Narcan, some gloves, and a face mask if you're going to give rescue breaths. And our second scenario was an opioid-associated out-of-hospital cardiac arrest, in which the participant had that same Revive kit as well as an AED on scene for their use if appropriate. Our participants went through these two scenarios, and we were able to pilot our evaluation instrument by observing the process measures performed by each of our participants within these scenarios. We video recorded all of these scenarios, and then we're able to do a retrospective review. So here's an example of what our simulation scenarios look like. The top photo is an example of what the participant would walk into, the scene that they would walk into. And then we were in an adjoining room able to be monitoring them from the back end and video recording their scenario. We used a high fidelity mannequin. His name is Hal. And the high fidelity mannequins are really awesome because they can be modified as the participant goes through the scenario. So we can modify their pulses, their breathing rate. He can make various sounds, etc. After the participants were completed the scenarios, we did retrospective scoring of the videos using the evaluation instrument. This was completed by 4 independent scorers. And we did create a reference manual that basically defined what we were looking for in regards to our scoring. We documented the participant start time for the various scoring timing components of our instrument, and then gave them scores whether or not the various process measures were performed or not. Since we had independent scorers, it's important that we wanted to establish inter-rater reliability. So do our independent scorers have agreement in how they score the various participants? And we did this using Cohen's kappa after all the scoring was complete, which I'll talk about in a little bit. So here's our demographic data from phase 2. Again, we were mostly looking for the diversity of experience amongst our groups. So we have some good diversity of experience. However, you'll see that some of our demographic data is rather homogeneous, which I'll talk about in limitations. And here are our kappa scores for phase 2 of our study. So inter-rater reliability is the extent to which raters assign the same score to the same variable. And a kappa statistic is a way that we can assess this. I know there's a lot of numbers here, so I'll focus your attention to our overall kappa scores for both scenario 1 as well as scenario 2. And our kappa scores, this is a table just to give you some reference if you're unfamiliar with kappa scoring, but our scores were within substantial agreement of each other. So just to touch on a few limitations of our study, as I mentioned, we had an ethnically homogeneous group that was drawn from one region here in the Appalachian Valley. And so this may limit the generalizability of some of our findings moving forward. Secondly, just to note that the results that we gathered were limited by the expertise of the participants and groups that we chose to focus on. However, we tried to limit this by doing thorough literature reviews and cross-referencing all of our information. And then with any qualitative data, there's always a risk for information loss as you develop the process measures. And finally, just to note, there were some limitations with our mannequin. So for example, while he could do a lot, we couldn't assess the depth of CPR compressions, which is just something to note. So just some takeaways and conclusions. Where are we at and where are we going? So we were able to collect qualitative information and use coding analysis to distill the process measures suitable for an out-of-hospital overdose emergency. We generated evidence for the development of our 2 evaluation instruments, which outline nuanced process measures a trainee should take while treating an opioid overdose. And then we were able to measure these process measures in simulation, which is an environment that is safe and controlled. So some future directions. We made a lot of progress with our evaluation instruments and established inter-rater reliability. A rigorous and comprehensive validation process is needed before we can reliably use this tool in OEND programs or various other simulations. So there's multiple frameworks that we can use as we think about this validation process, and we're going to choose to focus on Kane's framework, which assesses evidence across 4 inferences, including scoring, generalization, extrapolation, and implications. As I mentioned, this project really focused on a community level response to an opioid overdose, where you would come across a scene and regardless of your training, have very limited resources. So there's opportunity to expand our simulation scenarios to include more resources available on scene, or tweak and modify evaluation instruments to be expanded further than just a community level response. And finally, once we have a validated tool, it would be really great to be able to take that tool and implement it back in OEND programs and be able to address some gaps that may exist in their curriculums and help standardize that OEND training a little bit more. So thank you so much for your attention, and I'll take any questions. Oh, Dean Learman.
Okay, Allie, is this on?
Yeah.
Okay. Well, you brought out the inner nerd in me, as I'm going to tell you that it is hard work. The science of assessment and clinical skills assessment is hard work, and validation evidence requires, you know, a multi-study process. This is really an outstanding start, and it's really good to highlight what it takes to develop tools of assessment that can be precise and reproducible enough to be used in a whole disciplinary area. A lot of times when we review papers that are submitted to journals, it's like, you know, gosh, we made up our own. Isn't that cool? We made up our own survey, we made our own tool, and look what happened. And it's like you should have shaken your head. So, and you can see why people would go there, because it does take a lot more time to do it really well. So thank you so much for modeling that process so that we can sort of all understand it better. Well done. Thank you.
I definitely have a new appreciation for instruments in the validation process. So to go off your point, it's definitely a lot of work and a great team that's all contributed a lot to this project.
I just love that we've got a lot of qualitative data. I was kind of curious, when you did your coding, how was your intercoder agreement when you guys made the code book?
Yeah, so the code book was, I think, a really important first step as we kind of were coding. Frankie and I met together to kind of discuss what we were looking for and create the outline of the code book, and then work from there. And then we met at multiple times just to make sure we were in agreement with how we were scoring and kind of that process. And so I think anytime you do qualitative work, it's really important to establish those definitions and what you're looking for. And it ultimately was able to give us good themes and sub-themes that were coming up consistently between the both of us.
Allie, that was fantastic.
Thank you so much for your time.
All right, we have just 2 more presentations. The last 2 presentations, we're going to return to that rapid fire format. And so our next presenter, so we'll do the 5 minutes of presentation from 2 students, and then we'll combine the questions at the end. So first, we're going to hear from Chukwemeka Oekaneme, who worked with Dr. Sammy Lamouie, who happens to be our mentor of the year from last year. So shout out to Dr. Lamouie. He's from FBRI, and they worked together on a project entitled Interactions Between Connexin 43 and Beta Tubulin Isotypes in Glioma Stem Cells. Chukwemeka, do you want to?
Check, check. Hello?
Slide it up. Or maybe you're in your eye.
Oh, fine. Check, check. Perfect. All right. Well, thanks for the lovely introduction. My name is Chukwuemeka, and we'll be talking about this today. All right, so my research focuses on glioblastoma. This is both the most common and the most deadly cancer of the central nervous system. And it's so deadly because even with maximal therapy, which involves surgery, chemotherapy, and radiotherapy, it almost always comes back. And one of the reasons that it almost always comes back is the presence of these stem cells, these glioma stem cells. And when you treat the cancer and these stem cells are left over, they exhibit something called asymmetric division, which means they can divide into stem cells, more stem cells, but they can also differentiate into glioblastoma cells and replenish that population. One of the proteins of interest in this process is connexin 43. We talked about it. It's a 4-transmembrane protein, which forms these hemichannels that form, and 2 hemichannels come together to form the gap junction that we've been talking about, that Katie so wonderfully talked about. But furthermore, independent of this channel-dependent functions, it also has channel-independent functions within the cell. And that helps it act as either a tumor suppressor or a tumor promoter. So in our lab, we're able to differentiate stem cells by adding fetal bovine serum, and that differentiates stem cells into differentiated glioblastoma cells. And when you look at these cells under stochastic microscopy, you can see in this area on the left in the stem cells, there's more areas of white. And those areas of white are interactions between the purple microtubule and connexin 43. And you see that there's much more white in the stem cells than in the differentiated cells on the right. But importantly, this interaction leads to this tumorigenicity in these stem cells, meaning they survive more and they migrate more and they survive therapy more. So the other protein of interest, microtubules. These are heterodimers with alpha and beta tubulin subunits. They're very important in cell division and cell migration. They're very dynamic proteins. And within the microtubule, connexin 43 preferentially binds to the beta tubulin subunit. And a lot of research has been done on where exactly on connexin 43 the beta tubulin subunit binds, and it's here in this 36 amino acid residue region near the C-terminus. But it's not quite as specifically known on beta tubulin where connexin 43 binds. That's a wider 130 residue area on the protein, so less specifically known. And then furthermore, there are 9 different beta tubulin isotypes. And these isotypes are expressed differently. There's different profiles in different cell types and different cancer types. So how can we leverage our understanding of the connexin 43 beta tubulin interaction to target glioma stem cells and improve glioblastoma treatment? A couple of questions we needed to answer were which beta tubulin isotypes are present in our stem cells? And then what is the interaction domain, the specific connexin 43 interaction domain on this beta tubulin? So first we needed to identify which isotypes are expressed in our stem cells. So we did this through RT-qPCR, and we did find some significant results. So this is the first time we've been able to characterize the beta tubulin expression in glioma stem cells. And we see here these isotypes, 2A, 2B, and 4B are consistently highly expressed in the stem cells across the different glioblastoma cell lines. And notably, when we differentiate by adding the fetal bovine serum, those isotypes decrease pretty significantly throughout our cell lines. All right, that was at the mRNA level. So we did the same experiments at the protein level, and we also saw similar trends with our beta tubulin too. It tends to decrease as you differentiate your stem cells. And then the last thing we wanted to do was narrow down which isotypes connexin 43 binds to specifically. So we did this by taking a subset of that beta tubulin binding region. It's a connexin 43 mimetic peptide, a short sequence. And we performed something called a cellular thermal shift assay. And we saw that when we look at the interaction between this peptide and beta tubulin, it interacts more strongly with beta tubulin 2 than beta tubulin 3. All right. So to wrap this all up, some of the things we found that there's a high expression of beta tubulin 2A, 2B, and 4B in our stem cells. There's a high affinity for connexin 43 towards beta tubulin 2. And to further characterize this interaction, we want to make sure that we're going to overexpress our beta tubulin isotypes by using, we're going to overexpress our beta tubulin isotypes and perform co-immunoprecipitation experiments. You can see our preliminary results up here to do that. And then we also want to use in silico analysis to perform mutagenesis experiments, and that'll help us understand that specific connexin 43 binding domain on our beta tubulin protein. And just to reiterate, the reason we're doing all of this is so that by further understanding this interaction between connexin 43 and beta tubulin, we hope to be able to target this deadly stem cell population in this glioblastoma cancer. All right, I'd like to thank my whole lab. Everybody's very wonderful. And Smith Lab, Dr. Sheng, and our collaborator, and of course the research team.
All right, our last presenter of the day is Tony Anzavino. So like Maya Langman, who kicked us off in our first session, Tony worked with Dr. Eli Vlasavljevic from Biomedical Engineering and Mechanics, and this time with collaborators from obstetrics and gynecology to look at the feasibility of using histotripsy to treat uterine lyomas. All right, do you want?
Let's see. Go with this guy.
All right.
Standard. Is that all right, everyone? Unless you want me to run back and forth. All right. Last one of the day, but we were talking about another one of the Mount Rushmores of VTC research, histotripsy again. So let's get into it. Histotripsy treating uterine leiomyomas this time. All right. So this is a rapid fire. So you guys are going to get the info rapid fire. Can histotripsy treat leiomyomas? Big overarching things here are, first of all, what is leiomyoma? More commonly, it's called a uterine fibroid. These are worthwhile treating because they are the most common benign tumors expressed by women of reproductive age. However, by benign, I don't mean that they are harmless. These things can grow to be quite large, be quite painful, and often cause reproductive problems and many different things that they have to be treated for. So it would be definitely beneficial to have a good treatment for. Currently, our treatments consist of two sort of routes we can go: procedural treatments, most of which are invasive or have lots of complications, the gold standard of which is hysterectomy. And the other kinds of treatments would be pharmacologic, those mainly focused on symptom management. But neither of those things are what I'm proposing, which is the wonderful world of histotripsy. But you guys can kind of see, I really want to emphasize that the uterine fibroids here, if the gold standard is hysterectomy, trying to find a non-invasive, non-thermal treatment modality could make the world of difference for people. It would really preserve reproductive function and would be really important. So that was the basis of the clinical application here. So histotripsy, as we've heard before, is a rapid expansion and collapse of microbubbles at the transducer focus that allows for precise and complete ablation. This is a non-thermal ablation method currently used in liver cancer and other applications, and allows for rapid resorption of the treated volume. A lot of this kind of histotripsy jargon, basically to sum it up, is that you're forming this cavitation bubble at this transducer focus. So you're forming this bubble within the tissue, and that is what is kind of you're steering around the tissue to ablate the actual area you're targeting. So before I reveal our results, I want to just make one more kind of little note, because a little bit different than Maya's presentation, two things that we looked at were two different kinds of histotripsy in my experiment. The first was multi-cycle histotripsy, which essentially uses multiple cycles to push one's pressure threshold to the point that this cavitation bubble can form. So you're almost kind of like using multiple little, this is my medical kind of non-physics explanation, so bear with me, but like multiple cycles to kind of push that bubble into existence, where there's another kind of histotripsy, the newer kind, that's the single cycle that sort of pops that bubble into existence right away. We did this because multi-cycle was shown to be not as effective in fibrous, dense tissues. So if you're going to treat fibroids, we were sort of suspecting multi-cycle is not going to work as well. But single cycle had shown some promising research prior that the lab had done that it could treat fibrous things. So you'll see that terminology in just a moment. Just want to give you guys that brief heads up without getting too many more slides packed in here. One more slide before the results, sorry. This is our methods. To just give you a little bit of an explanation, we have our tank of degassed water. We have a ultrasound probe here to visualize what's going on. Here's a fibroid, a little ex vivo fibroid provided courtesy of Dr. Casey. And then our histotripsy transducer. And that fibroid, you can't just hang tissue like that within all this medical apparatus here. So you embed it in a gel phantom. So you embed the fibroid in the gel phantom, and that's how you do the treatment. At least that's what our ex vivo setup looks like. So without further ado, we'll talk about the results. The first is the multi-cycle trials. This here is a little picture of the multiple cycles and an image of what this looks like. I know we probably haven't seen a whole lot of actual histotripsy other than those in the lab, but there's no real cavitation bubble going on here. It's very, very diffuse. So to be expected, we have our H&E as well as our trichrome stains, the trichrome being added because we want to look at that fibrous collagen network, and that's what you can really get with the trichrome. From one to another, where we're not seeing much of a difference in the untreated versus the treated. You know, we're still seeing quite a lot of cells down here. So overall, treatment showed no real observable damage, and that there are very minimal changes to smooth muscle fiber spindles and surrounding collagenous network. So semi-expected with multi-cycle trials, but that was our first thing. And then the big kind of take home for any of those that visited the poster earlier is the single cycle trials. For those that did visit the poster, you would have seen that I displayed not just 4,000 pulses per point, but 2,000, just like the previous multi-cycle, as well as 10,000 pulses per point. Those can be thought of as sort of the dosage we're applying, the amount of histotripsy we're applying to a certain area before moving on. So the amount of that bubble sitting in one area. And I included 4,000 because that was the most kind of fun results to share with you today, because the 2,000 worked as well, but this one worked even better. And the 10,000 was sort of just for completeness sake. We really just toasted that thing. So the sorry, Dr. LeConte. So here the encouraging thing is, as I pointed out with our H&E, lots of cells, but we're not seeing a lot of cells anymore. So that is what you want to see when it comes to the histotripsy. We're getting a well-defined bubble cloud as well. We can see that up there. And so we got that. We got coagulative and liquefaction necrosis happening, marked loss of myocytes, a collagen network replaced by eosinophilic material without nuclear cytoplasmic details. So we liquefied that thing using the single cycle histotripsy. And yeah, I pointed out the H&E, but you can also see even the trichrome. We're looking at that more collagen network that has been pretty obliterated as well. So very encouraging and very exciting to share with you. Really grateful I got to do that. So the big conclusions: multi-cycle is less successful at treating this, really not successful. Single cycle did form that bubble cloud we were looking for and was successful treating these. And we got next steps coming, hopefully. Thank you to the lab, Eli, especially the work at Carillion with Dr. Casey and Dr. Valleja getting this whole thing off the ground. And then I've seen Kara Spivey here too. I want to thank her personally. She really makes a big difference for a lot of us. That's right. All right, thank you all.
All right. Tony, thanks for the great data and enthusiasm to end our day. All right, now you
I
can
can't
ask
help it.
questions of both our speakers.
Tony. Thanks, Tony. That was a great talk. I have a question, but a comment first that a lot of people are looking at minimally invasive ways to treat symptomatic fibroids. The one to beat now isn't so much hysterectomy as it is uterine artery embolization, which is the gold, sort of become the gold standard in non-hysterectomy treatment. And a lot of different studies going on, high frequency ultrasound, thermal, cryo, all sorts of things. And this Mount Rushmore is definitely worth it to hit the histotripsy. Question for you is, can the model that you've used, the ex vivo model, can it be adapted so that you can reproduce the unusual anatomies we sometimes see in a uterus with fibroids? So sometimes you're going to be moving through not only a bunch of more superficial tissues, but even within the uterus, various interfaces between normal uterus, other fibroids, and adenomyosis on your way to getting to the lesion of interest, which can sometimes be really deep and near the endometrium, which is why it causes so much bleeding. So is there any way to do that in an ex vivo model using the gel and some configuration, or would you have to move to an animal model or something else?
Yeah, that's a very good question. I think the lab's definitely taking multiple approaches. I don't know if we need a double microphone here. I'll just answer you like this. Thanks, Samantha. But the lab's kind of got a couple different angles it's trying to do that. There's multiple tests going to see what the effect of hysterectomy is on multiple different kinds of fibrous tissues. So what that's like, but then yeah, using different kinds of gel types, more denser gel types that you're embedding the phantom in is another way that we could get at that. But yeah, there's still there's still definitely multiple steps between here and placing this on a patient. I think that would have to go through first.
This question's for can you elaborate on how your research?
Yeah, yeah, thank you. That's a good question. And it does get, as a basic science person, it gets hard to see the forest of what I'm doing this for from the trees of just the everyday research. So it's always good to come back to that. But just to reiterate, the two proteins that we look at, beta tubulin, connexin 43, they interact in this very hardy stem cell subpopulation to make it essentially come back after treatment. Even if you really blast at it, it comes back. So in a patient, if we're able to interrupt this interaction at the cellular level, then hopefully that'll help eliminate this really kind of deleterious stem cell subpopulation. And there was a time when, interrupting protein interactions in a patient was considered, kind of impossible. But a lot of treatments have come to light in the past, 30, 40 years. One example, a really popular example that we use is cystic fibrosis treatment. So you can basically gene edit to cause a protein to fold a different way so that it doesn't interact with another protein. But there are also drugs that interrupt proteins, in the cellular environment itself at the protein level. So I think with this research and understanding that interaction, we can design something that'll interrupt that interaction and treat the stem cell population.
Chuck, I wanted to actually perfect setup. I wanted to say to you, I actually think the work you're doing is foundational, even though we're trying to understand at a very cell biological level the interactions that you described. You think about the 13,000 people that will be diagnosed this year with GBM, and 90% of them after resection and radio treatment and chemotherapy are going to die within a year or so, right? And so the stem cells that you're working on that's the story right there, because that's what's left after the resection that really just buys you a few months. So a fundamental understanding to give rise to how to strategically design targets for getting at GBM stem cells is going to be the answer. So I just want to hearten you a bit. They talk about on the shoulders of giants, 20 years from now, 40 years from now, whatever it might be, this work and other work related to it are being the basis of saving an enormous amount of lives. So congratulations.
Thank you.
Thank you very much.
Good.
All right, so the serious awards were the letters of distinction in research scholarship. So everybody who spoke today has their name and their mentor's name and their project title on a plaque. And for those of you who blaze right past it every time you walk down the hall to the Dean's Suite, take a moment and stop and look. So all of our plaques from all of our years are up. And so this is where class of 2023 will also live. So thank you very much. I'm excited about that. Okay, and all of our students presumably voted on 7 different, did I say that? 7 different categories of awards. You looked around at all the posters, you selected the top awards, and now we're going to hear who got all these awards. So come down if your name is called. So for the most likely to trend on social media, that was Patrick Barrett. You have to sit in the back. Huh?
Thank you.
Crystal. All right, let's see. The next one is, in recognition of Best Visual Design, Luma Abunimer. Also sitting all the way in the back. All right, Best Poster Presenter, Katie Brow. All right, in recognition of most hurdles overcome, and there are many, many of you who could have qualified for this, but this one goes to Kendall Carter. Again, acquiring sheep shoulders is not easy. All right, most exciting discovery goes to Maya Langman. Most likely to change clinical practice this year goes to Sham Bhatt. And finally, most promising preliminary data for an NIH grant, Tony Enzavino. All right, before I let all of you go on this Friday afternoon, I have to thank a lot of people. First of all, to our faculty mentors and faculty evaluators who really help shape our students' projects over the course of 4 years, from the very beginning stages to the very end. Thank you to those of you who are here and who help out all the time. I also want to thank Dr. Taggy. She wanted to be here today. I know many of you have worked closely with her. She's home with a sick kiddo, but she sends her congratulations to all of you. So thanks to Dr. Taggy. Yeah. I want to thank Dr. Nikki Worthington for all of her support throughout the year. She's really beginning to play a pivotal role in helping run this research curriculum. Thanks, Dr. Worthington. And then we've already heard her name once spontaneously. You know how critical she is. Kara Spivey is an incredible member of our research team. Thank you, Kara. We had a lot of help getting this event going. Brian Stanford from VTCSOM, our communications team, Catherine Doss, Ryan Anderson, Vianne Greek, Josh Myers. We had a lot of great stories and videos put out by this group and a good event. So thanks to all of them as well. Dale up in the back, thank you for all of your help today. Very much appreciated. We had a lot of people scrambling to get that survey off the ground. Dr. Mutchison always helps us every year with it, and Jessica Flowers, Crystal, all help with that survey. I want to thank also Dean Learman and Dr. Friedlander for the school's continuing commitment to research throughout all 4 years. I think it takes a special medical school to commit to this, and I'm always grateful for their support for this. Okay, and last but definitely not least, this doesn't happen without Jessica Flowers and Crystal Barnett, and all of you know that. So help me give them the biggest round of applause. All right, thanks everybody. Have a good evening. Wait, what? Oh, yes. Okay. If you spoke today, can you please come down front? So all of our letters of distinction winners, please come down front. And your posters have been taken down. Please retrieve them. Don't throw them in the trash. Please retrieve your posters.